by not taking much time, I would like to invite our speaker, respected Dr. Leon Ogoti sir. Dr. Leon Ogoti sir is a convener, Public Health Committee of Kenya Medical Association. He is the executive of the Association of Travel Medicine and Vaccine Services, Kenya. I request Ogoti sir to please start the session. Over to you, sir.
Is my screen visible?
Yes, sir.
Okay, so thank you very much, Dr. Idraniel. As he said, my name is Leon Ogoti, and I work in Kenya, and I do a lot of public health work in Kenya. And with the pandemic period, of course, the profile of public health has really been raised. So we've had quite a lot to do in these sides where the public healthcare system is not particularly the best. So we had a lot to have to put in place in a very short period of time. So my topic for today is really just a perspective, a Kenyan perspective, to just look at the role of personal conscience in the whole pandemic, and whether that has any role to play in the decisions that are being made by the governments and researchers. So about 2 months ago, I was seeing patients in a clinic, a routine clinic, and I met a lady who came in for a consult. She was diabetic, and we just got to talking as I was taking a history. I was a patient I was seeing for the first time, but it was not her first time visit. And at some point, I happened to ask her whether she'd gotten the vaccine, and she mentioned that she hadn't. So I was very curious because she was living with a chronic disease, the people at highest risk. So I just happened to ask her why she hadn't gotten the vaccine. And she got a bit upset and said she was tired of COVID and all the COVID business. And I mean, it had cost her so much, with the government lockdowns and everything. Her business had crashed. She was struggling for money, all these things. So, but all the same, I just took a bit of time to encourage her and tell her that it was still good for her to take the vaccine. And then we continued with the session. So when we were almost done, she asked me if the vaccine was available in the facility. And I told her just to give me a minute to confirm, because sometimes it's there, then there's a stock out for a bit, then it comes back again. So I went confirmed, and at that moment, it happened that there was no vaccine available. So I told her, and she said, doctor, this is the real reason why I'm tired of this vaccine and the vaccine business, because at least two times I've come or gone to different facilities looking for this vaccine. They tell me it's so important because of my condition, but when I go look for the vaccine is not available. So then I wonder, is it really that important? It's been such a long time that we've been under curfew, almost 2 years. We've lost so much, but this vaccine that you keep talking about is not available. So it just got me thinking, really there's been a lot of talk everywhere about how, there's hesitancy and people are worried about rejecting the vaccine for religious reasons or for cultural reasons, all these things. But then I wonder, in some setups, lower middle income countries, is this really the case, or are there other things at play? So might we be blaming the wrong thing and trying to bring in all these other reasons why vaccination is not happening as it should? So for Kenyan perspective, our population is about 48 million. These are our demographics. You can see most of our population is young. Most of almost half the population under the age of 24. This is our COVID situation so far. This information is publicly available online. So you can see what our population of about 48 million. We've not had too many cases confirmed. Again, our testing, I can't say has been at the highest level, but we've done relatively well. Our mortality rates are also quite low, our case fatality rates to COVID. So far, the fully vaccinated people are only about 2 million, which is still a long way off where we really need to be. So far, when you look at the government's approach to COVID and to everything pertaining COVID, it's really been about, it's sort of been instructional, what I would call deontological, where they set certain rules, certain laws, and they just expect everyone to follow them. The consequences of that have notwithstanding. So when things came into force, COVID began, put on your masks, stay at home, don't go to work, be at home by a certain hour, social distance, they've closed all gatherings, no political gatherings, no church gatherings, they've locked down places where people socialize, such as clubs, entertainment, sports, restaurants, all these things, without much concern for what are the repercussions of all these actions. What are you really expecting people to do? Then look at what conscience really is. So this is just based off of one's philosophy or value system. So how is one's mindset set based on what the things they believe in? And does this have a role? Is this important, or is it just a matter of government has said, so let us do? So these are some of the things some of the impositions that were put in place by the government when COVID came into place. And I guess this were global, was spread across the world. So I mean, I think they're pretty much the same things everywhere, even where you are. So these were movement restrictions, the insistence on COVID-19 protocols, the usual masking, social distancing, really pushing for hand washing and provision of the facilities for the same. Then lockdowns and curfews where people are supposed to be indoors by certain hours, and lockdowns where people are supposed to be moving around in certain areas, or the movement even in certain areas are very restricted. So when we look at movement restrictions, the examples we had in Kenya of Kenya is divided into 47 counties. So at some point, there was free movement between the counties, but you could not move out of the borders of the country. Then when the cases got really high, there was a metropolis area that was cordoned off, so you could not come into or move out of the area. Now, because of the nature of things, one of the areas in the metropolis is a capital city, sorry. And people work here and live outside. Of course, because of the high costs of living within the city, other people live outside. So all this was, not considered when they just locked it down. So people who are working within the city and live outside, or vice versa, couldn't access their workplaces. It just happens that I was one of the people, even as a health worker, who was, locked out and would have a really hard time now having to go to work. So they would say, for example, just move next to your workplace without consideration for someone, their family, what is going on, what is really their situation at the time. There was also the impact on movement of goods and services, and this was severely affected. And then one of the things that we really noticed at the time was even people who attend chronic disease clinic visits, because the 2 or 3 major hospitals within the country where a lot of specialists are located are within that metropolis region. And people who didn't have access to passes, such as medics or security officers, couldn't come to this area from outside, so they couldn't attend their clinic visits. And this was also not considered. So they were just, left out. So these are just some of based on the approach which was a good approach. I wouldn't say that it wasn't, but that was taken. It really didn't consider much the role of the individual and their wants and their concerns. It really didn't consider that much. So again, for the COVID-19 protocols, there was the issue of masks, for example, which were one of the highest considered in terms of prevention. And you could see there was challenges with costs that people were facing because masks, pre-COVID, a box of masks, 50 surgical masks, would probably cost you around 350 Kenyan shillings for a box of 50, which is one mask for about 7 shillings. When COVID began, the cost of a mask of a box was about 3,500 to 4,000. So that meant a mask was going for as much as probably 50 to 60 shillings. Now you're considering a place where most people probably spend about $1, which is 100 to 110 shillings. So you expect them to have a new mask every day. So they spend half their household income on one mask. So if it's a household of 5, how do they share that around? Is it one mask to be used by a person going outside? So of course, all these things, much as we were talking about, really using this as a preventive measure, you wonder about the hygiene of the masks. There was also the issue of people having to recycle, masks being picked up off where they had been dumped and washed and repackaged and resold, a lot of other things. So it was almost as if every other disease was not important except COVID. Penalties were also in place for people who were unable to adhere to social distancing measures or unable to wear masks who are not wearing masks in public. And maybe the penalties were justified. So you'd find the police would move around, fine the people very highly, about $2, about $20 if you were found without a mask. If you didn't have the $20, you'd be bundled into a truck. So a lot of people will be bundled into trucks and sent off to prison because they didn't have masks. But then in those places, they would be very crowded, which now defeats the purpose of why you're asking them to wear the mask in the first place, because you're creating microenvironments for the spread of the disease. So all these things were pushed again on the individual. All these rules, all these laws were made for the individual, but they were not really considering how the individual feels and really the situation of the individual at that point. Again, the curfews led to really a lot of economic impacts. People lost jobs massively, especially those in the entertainment industries and other industries that work at night. We had curfew from March 2020. It was only lifted in October this year. So that's about 20 months of curfew. Suddenly and without any means of compensating those who had suffered at any time. And then one thing that was very key and critical that was noticed at the time was that when they put in the curfew, there was no provision for people who might need emergency medical care. Taxi services were cut off. Hospitals were open, but taxi services were cut off. There was no public transport. So anyone who did not have a vehicle, which is very few people anyway, would simply not be able to access or couldn't get access to a vehicle at night, would simply not be able to access medical services. And when we look at the issue of maybe obstetrics and other emergency surgical cases, you really wonder about, wow, this is very strange. You're trying to prevent one disease, but you're causing so much chaos on the other end. So vaccines came, and it was seen as such a redemptive feature because, basically the pandemic would be over if everyone just got vaccinated. And vaccines have done so much in the past century and this century as well in just prevention of disease, especially childhood diseases, because in areas such as ours, that's really what we use them for childhood preventable diseases, not too much adult vaccination. So for us, it seemed, I mean, it only makes sense that everyone should embrace vaccines, because the faster we get vaccinated, then the pandemic is over. Curfews, lockdowns are lifted. We can go back to business and at least resume a sense of normalcy. But again, this hasn't really been the case. So we wonder, we look at the news in developed countries, and we see now there's so many people who've been vaccinated, and now for the rest, it's a matter of their own conscience. They feel like they don't want the vaccine. They have their own questions, whether it's religious or whether it's cultural. They just have their own personal beliefs why they should not receive the vaccine. But the same story is being spread around, even to places where that might not necessarily be the case, right? Where it's not necessarily that people don't want the vaccine. It's now a question of, is the vaccine available? But the same story is being told from the developing countries from the developed countries is being told in the developing countries, and really have to examine whether this is really the case. So when we look at the backdrop against which vaccines came to this part of the world, say Africa, and maybe at least Eastern Africa, by the time the vaccine got here, which I think we got our first doses in April this year, by that time there'd been quite a bit of vaccination efforts, because I think maybe they started in December last year in some parts of the world. So the delays in the vaccine getting here meant a lot of rumors had been spread. There'd been a lot of rumors and falsehoods about COVID, but even for the vaccine, there's a lot of time for those to spread. Vaccine hesitancy has always been an issue in this region. We've always had an issue with people being hesitant about receiving vaccines, especially for the childhood vaccines, because of issues that they say they cause infertility and things like those. There's rumors about autism and such things. Again, as I have mentioned, adult vaccination is not very routine here. Dr. Adrian Neal mentioned that I practice travel medicine, and travel medicine is a part of it is about vaccination. So you end up doing a lot of adult vaccination, and you find a lot of people associate adult vaccination with travel, which maybe may or should not be the case. But then it's not common practice for people to get vaccinated here as adults. Mortality rates are just not as high. Since COVID came, we've only recorded about 5,300 cases. 300 people have lost their lives. So maybe people don't consider that too highly. Many parts of the country have been skeptical of COVID all through. Many parts of the country, apart from the metropolis area that I had referenced earlier, and a part of the coast where they've had quite a significant number of cases. Many places have had very few cases. Some counties, I think, had reported, even by May, June this year, they had reported, and these are pretty large areas, probably one case. So some areas were really not, yes, there is COVID in the country, but we don't really have COVID here. So even the public health measures there were not really, things like masking were not really a part of their daily lives. It was, if you went into these areas, you'd be the only one probably wearing a mask. Then again, we are nearing an electioneering period, which is next year. So campaigns were also in high gear. So you'd find the government is making certain rules, but then they're being violated when people are having political events and rallies, and there's mass crowding and there are no masks in such areas. So I think creates a sort of dissonance also for the individuals, because they're wondering, you tell us is this, you've locked the country, we can't do business, we can't do this, that, and the other. But on the other hand, you're violating the same rules that you're putting in place. So you really wonder, when you bring in the vaccine, how seriously do people, given the backdrop against which these vaccines are coming, are really people going to really take them up when they don't even believe COVID is a real problem? Is it even real? There's been all this talks of, money that was given for COVID has disappeared, or so many different tales around the disease. And then we look at the reality of the vaccine situation. So since March, April this year, vaccines have slowly trickled in. So there's really not been too many vaccines available. For a long time, we only had AstraZeneca. And then there was all this talk, oh, is Astra the most efficacious? The people who had access to knowledge, should we wait for Moderna? Should we wait for Pfizer? Those are said to be the best. Everyone is saying take what is available. Some people are saying, no, let's wait. This Astra is not the best, or maybe it has this and this consequences. So let's wait for the others. Again, there was the issue, another issue comes into play that I found was pretty significant, where when the Sputnik vaccine was available, it found its way into the country privately. So there are people who were able to bring in the vaccine privately, and then it was being sold. So this was an issue again, because when we're having a public health issue and then certain people are bringing their own vaccine, it creates a lot of routes, now for people to begin distributing what could be vaccine or what could not be vaccine. And it was actually seen where certain incidences were reported where people are being injected with water and told that they've been vaccinated, and maybe now they've paid for that, and just certain funny things. So it was creating an avenue for a lot of strange practice to begin to take place, and this was shut down by the government. But it's still suspected to maybe have continued, but very low key. And of note is that some senior government officials also seem to be taking the vaccine that had not been brought in by the government. So this created, again, questions for the public. And then now we're talking about vaccine mandates that have begun to be issued. But then you find you're issuing a mandate for vaccines to be administered, yet there really isn't much vaccine. So there are people who are looking for the vaccine, can't get it. But you're asking people who are not sure whether they want it, you're forcing them to get it in order to get to certain workplaces. So it just creates a big issue again. Some people do want the vaccine, you're not giving them, you're giving it to people who don't want it. Where are we really on this? Then the issue of questionable vaccines, as I've just mentioned. So when you look at freedoms, our constitution locally is very clear. I've cited 2 articles here, and they just talk about freedom from discrimination on the basis of conscience. So my personal beliefs should always come into play, unless I'm infringing on the rights of others. And then the right to freedom of conscience again. And one goes further to say that one shall not be compelled to act in any way that is contrary to their belief. So as I demonstrated earlier, and I've given multiple examples, this has been the case persistently with during the whole pandemic period, where people's beliefs have been shunned to the side, and a deontological approach has been taken, and they've been told whatever you want is not as important as what we are telling you. And that may be the case, but many times that has not also been in the best interest of the people, and many people have died of other diseases. Probably more people have died of other diseases than they have died of COVID, in the same place where that agenda has really been pushed. So you again wonder, what about our freedoms? What about our rights? Then the church, I think the Catholic Church, that's usually very opposed, maybe at times, to the vaccine. They've also mentioned that it's not a moral obligation for one to be vaccinated. It must be voluntary. It comes down to a choice of one's health versus the common good. But again, if one is not being vaccinated, then they should do their utmost to prevent infection to themselves and others. So all these things again come into play, where it's really meant to be a voluntary action. So you're really meant to be encouraging so that more people volunteer for vaccination, especially in a setup where the vaccine may not necessarily be as available as in other places, because you're making it an obligation. So is this really helping or working to create more hesitance? So I think in conclusion, my keynote was really meant to be just a picture of, yes, we're talking about personal conscience and it is important, but we're also maybe creating a false picture in certain places where people are not really making the decision to get the vaccine or to not to get the vaccine. The lack of vaccine is making the decision for them. So we are not even at a point where we are making the decision consciously, yes, I want the vaccine. It's just a matter of there's vaccine or there's no vaccine. But then the story that's being told is a bit different. We're not really focusing on the lack of vaccine. It's more of this vaccine, but people are rejecting it. So in conclusion, vaccine mandates in lower middle income countries where our freedoms and rights really have been violated throughout the whole pandemic period at great cost to life and economic capacity. I think they are a bit premature and will only heighten hesitancy. People still have a lot of questions and doubts about the COVID and the COVID vaccines and all these things. And now pushing the vaccine on them really will more likely make them fear it more rather than encourage them to take it. So I think it is the imperative of pharma and governments and all other stakeholders in the vaccination process to ensure access to high quality vaccines and proper and safe delivery systems, and combine this with mass public education on the benefits of the vaccine to ensure at least we hit a critical mass that some of the countries in the developed part of the world have hit. And then for the few who remain, or for the number that remain, then we can now consider working on these discussions of whether conscience is more important than public health good and such things. But before we have full access to everyone who needs it, I feel it's still a bit premature. Then only after we have done so, we provided safe vaccines for everyone, then can we expect the unvaccinated now to begin being responsible for the decisions they're making and really challenging them on the repercussions of you've not been vaccinated. If you get sick, who do you expect the public healthcare system to take care of this issue now that you're sick and you refuse vaccine? How does this affect if, for example, too many unvaccinated people are now severely ill and they're in the hospital? Would you then have other people with other diseases not be able to get in critical care services? So all these discussions now come into play, but only after we have provided and ensure that everyone who wants a vaccine has it, and not that you're using this as an excuse that it's people who are refusing it. So throughout the pandemic, and personal freedoms have been violated without really solving the systemic challenges, right? So there are a lot of health system challenges that exist. And if this was strengthened, it might ease the burden of the pandemic on our countries. So let us not vilify personal conscience and use that to excuse poorly managed vaccine efforts in lower middle income countries. So that was my talk. Thank you. Thank you very much for your patience, for listening. Yeah.
Thank you very much, sir. Any questions from audience? Thank you so much, Dr. Ogoti, sir, for such an informative session. It was a great learning experience for all of us. And thank you very much, sir, for giving your valuable time.
Thank you. Thank you very much.
Thank you, sir.
Indranil, we do have the paper poster presentations, right?
Yes, sir.
Okay.
Yes, sir. We can proceed
So-
with the paper presentation session now.
Okay, so you will be moderating that, Akshay? Or
No,
Shubham is
sir.
joining?
No, sir. The team, scientific committee team will join. I think they are
Okay.
already here.
They're already here. So I think they can take over and they can start the session.
So I request scientific committee, who is moderating today's session amongst the scientific committee. May I know?
Sir, I think we have Shravya and Harshita. I'm not sure if they have joined yet. Are you guys here?
I think the presenters are already here. Okay, we will
Shravya
have
and
a,
Harshita?
yeah, I will try to contact them. Probably they are here only. They are unable to unmute themselves. I will try to solve the technical difficulty. Guys, we will have a break of 5-10 minutes. And once the judges are here, I think we are waiting for the judges. So once the judge is here, we can start.
Excuse me, Piyush sir. I'm one of the moderators for today. Could you please make me co-host?
Sure.
Yeah, Piyush, can you make her co-host, please?
Yes, I'm doing that. Done, ma'am.
Thank you. Good morning, everyone. I sincerely apologize from the side of the Ethos Scientific Committee. We're having a couple of technical difficulties as the two moderators have not joined us. Please give us 5 minutes while we sort this out. Thank you.
We are extremely sorry, guys. We are waiting for our judge, Dr. Shimpa ma'am. She is busy in some case as the information we have received. So that is why this delay is happening. We are trying to get in touch with her, but then her phone is, phone is outside and she is busy in some case. So once she's free, we will start with the session. We are extremely sorry for this delay, and we apologize for that. We will let you know. Just be here with us. I hope the poster presentation has started well on platform B. Till that time, you guys can also see the poster presentation if you all want.
Guys, we just got an update from our judge that she will join by 10:30. Again, we are extremely sorry for this delay, but then as you all know, you all are from the same medical field, and ethics is all about caring patients and putting them above all our all our duties. So she was caring for that patient, and she was giving a practical demonstration of what bioethics means to her. So that is why we will start the session at 10:30 a.m. now. And don't worry, we will try to finish it off as soon as possible so that you all can join your work after 11:30 a.m. Also, guys, let me tell you, by the time that Ethos is going on very well, this is day 4 of Ethos. And till now, we have completed our various events like Ethscan, debate, and all of them were very interesting. I hope you all enjoyed them. We are constantly updating our Insta page, and Shreya is can share those documents with you all, those pictures with you all, which we took about the events. And let me tell you guys that after the event, we will also release our magazine. So guys, wait for 10:30 a.m. Once our judge, Dr. Shimpa ma'am joins, we will start the session. Dr. Shravya and Dr. Harshita are there, if I'm not wrong.
Yes.
Yeah. So I think ma'am has joined now. So we can begin with the session, right, Shravya?
Yes.
Yeah. Thank you everyone for waiting with us. Now let's begin the session.
A very good morning, everyone. Today we are starting with day 4 of Ethos. My name is Shravya Shetty, and I'm a second year MBBS student at DY Patil Medical College, Kolhapur. And I'll be the moderator for this session along with my co-moderator, Harshita Umesh.
Thank you, and thank you, ma'am, for joining us. We'll have a brief introduction about ma'am, and then we'll get started. Ma'am, can you hear us? Good morning, ma'am. Can you hear us?
Ashita, can you please check if she's able to unmute herself? You are the co-host, so just go and click her the options there over her name and ask her to unmute.
Dr. Shimpa, ma'am, can you hear us?
Arshita, did you check if she's able to unmute herself?
She can do that, sir.
Okay.
But ma'am hasn't replied yet. Ma'am, could you use the chat box if that would work instead? Good morning, ma'am. Can you hear us?
Can you hear me?
Yes, ma'am, we're able to hear you.
Oh,
Thank
okay.
you so
I
much.
can hear you now. I think that must have been a glitch. I can hear.
All right, thank you, ma'am. So, Shravya, could you please present your screen and we'll start off? Shravya, are you here? Okay, no worries. I'll just do that. Good morning, everyone. Thank you once again for being patient with us and waiting with us. And thank you, Dr. Shimpa Sharma, ma'am, for joining us today. She will be the judge for today's paper presentation. A little bit about ma'am. Dr. Shimpa Sharma is an alumnus of the Lokmanya Tilak Municipal Medical College, Mumbai, where she acquired her MBBS and MD General Medicine qualifications. Presently, the Pro Vice Chancellor and the IQAC Director of the D.Y. Patil Education Society, deemed University, Kolhapur. She is a professor in medicine at the Medical College and a FAI MER Fellow 2019. With her research and publications, she's a keen researcher and has 24 index publications, of which 10 are in Scopus and PubMed, 4 research papers on ethical issues to her credit. She has published 1 book and has applied for 3 copyrights. Her interest in bioethics dates to her 4 years of experience as professor and HOD at an international medical college in Mauritius. It has been strengthened through the association with UNESCO Chair in Bioethics and now the International Chair in Bioethics WMA Cooperating Center. Thank you so much for being here with us, ma'am. So shall we begin with the paper presentations?
Yeah, that's good.
Ma'am, do you have the score sheet with you?
No, I have not received any communication actually. If I could get something, that would be useful. Otherwise, if you could give me the headings, I could create it.
All right, ma'am. I'll just share the headings with you, or if you could just send me your number on the chat, then I'll just send it to you right away.
I think give me the headings.
All right, ma'am. So the category, we have this being marked for 100 marks. So there are 5 categories in total, and each one has 20 marks. The first one would be originality and creativity, theoretical or clinical significance of research, creativity.
If I'm writing it down, you'll need to slow down better.
Ma'am, shall I just copy paste it for you into the chat box?
Yeah. Why don't you put your file in the chat box? I'll download it here.
All right, ma'am. I'll do that.
Yeah, great.
Share screen.
Ma'am, it has been shared. Could you please let me know?
Yeah, I'm just downloading it. Give me a sec.
All right.
We have 10 paper presentations totally.
Yes, ma'am. And I'll edit the names as we go along so that you can just enter the score sheet as it is. Would that be all right?
A little difficult because I'll have both the, one sec, let me just reduce the window. Yeah. Okay. That should be good. Yeah, I think you can carry on. You could just edit the names and I'll move with that.
Yes, ma'am. Just send us an edit access so that we can just confirm that for you. Because I believe this
signed
is...
in. I'll have to download it first, right?
Yes, ma'am.
Oh dear.
Ma'am, that should be an online document. It's a Google Sheet.
To share access, I would need to download it into one of my IDs, wouldn't I? You'll have to help me out on that.
Otherwise, ma'am, you can just click that button on the right upper side. It would say request edit access.
All right, let me see that. Button on the right. You know, you people are so fast at it, you'll almost scare me. Okay. Where does
right upper, ma'am.
No, I think he's still asking me to sign in.
Oh, all right, ma'am.
Yeah,
You may just
download.
download.
To sign in.
Okay, okay, ma'am. Okay.
Give me a sec.
मेरे से लॉगिन किया नेम चेंज कर इसने मेरा लॉगिन था ना तो इसने मेरे को बोल रहे भाई आर यू शेयरिंग योर स्क्रीन मैंने बोला मैंने थोड़ी
What ID should I share it on to, beta?
Ma'am, any ID is all right. We'll give you.
I don't have any of your IDs. So if you could give me one ID on which I can send it over, I could send it to you.
Do it as if you click on the button that
No. Harshita, she's not asking that. She's asking write your email ID in the chat box. Okay.
Perfect.
So that she can send it to you. Okay.
Thank you. That's what I needed.
All right. I'll just do that. 1 second.
Yeah.
Ma'am, it's been shared.
Okay. Thank you.
Anytime.
Harshita, I want you to write your email ID in the chat box. Can you do that for the Zoom? Zoom chat box. No, we cannot see your message. Sorry.
No, I can see her email ID.
Oh, you can see. Great. Okay.
I am just taking a little time because I have to type it down. It was 21, am I right?
Yes, ma'am.
Why doesn't it take that?
Don't know, ma'am.
Yeah, it's really not. Okay, 1 minute. What I'm doing is I'm just sending you the link in the chat box.
Okay.
Somehow not taking your ID. I'm sending you the link, sharing it back with you. So now I think that should be good. Can you check it out so we can proceed?
Yes, ma'am. Just give me 1 second.
Yeah. Oh, yeah. I can see your updates.
Yes, ma'am. It's working, ma'am.
All right. Perfect.
All right, participants. Thank you so much for the patience and for waiting with us and for ma'am. We will begin. Our first presenter for today is Dr. Komal Gade. Dr. Komal, are you here? Dr. Komal?
Harshita, I'll request you to change the... why am I not able to edit it? Have you given me editing rights?
Could you just send your email in the chat box and I'll give you editing rights? You should be able to edit it.
Not able to right now.
All right, ma'am, just send me your email and I'll give you edit access immediately. In the meantime, Dr. Komal Gade, could you please unmute? Ma'am, you should be able to edit it right now.
Yeah, because you've got the names in the wrong column. If we could just put the names in the right column, that would give me space to score.
I'll do that right away.
Yeah.
Ma'am, I believe Dr. Komal is not responding. So shall we proceed to the next person?
Absolutely. We just go in sequence and take them one by one.
All right. Dr. Shraddha, are you here?
Yes, I'm here. Am I audible?
Yes, you are. Thank you so much. So just before we begin, I'd like to restate the rules for you guys, and
Okay.
I'll share my screen with that as well. Just give me 1 second. Can you see my screen?
Yes.
Okay, so each presentation can have only one presenter, who would be either the author or the co-author. The time allocated for each presentation will be 5 minutes up to a maximum of 7 minutes. There will be a dedicated 2 minutes of time for question and discussion after the presentation from judges and the audience. The session presider will read the questions submitted. The presentation will be live on Zoom with the judges and probably the audience. You'll be asked to share your screen for the presentation. If you don't want to do it yourself, the moderator can do it for you. Please turn on your webcam so that the judges/the audience can see you during your presentation. So shall we begin?
Yes, I think we can start.
All right. Piyush, could you please allow her to share screen?
Yeah, she can do that.
All right. So I'll set the timer then, and let's begin.
So good morning, everyone. Am I audible?
Yes,
Dr.
very much.
Shraddha, your time starts now.
Okay, good morning, everyone. So my topic for today's paper presentation is clinical profile of diabetic retinopathy in tertiary care center. Myself, Dr. Shraddha Gaul, and co-author for this paper, and my guide is Dr. Vivek Sahasrabudhe, professor and head of Department of Ophthalmology at SCGMC Nanded. So yesterday we all celebrated World Diabetes Day on 14th of November. We all know that in recent years, there is increase in the global prevalence of diabetes mellitus, and it is according to the International Diabetic Federation, it is proposed to be at around 700 million by the end of 2045 from 463 million from 2019. Diabetes causes life-threatening macrovascular as well as microvascular complication. Diabetic retinopathy is one of the most important microvascular complication which leads to the visual morbidity, and hence it is also included in the Vision 2020 program. So there are multiple factors that affect the diabetic retinopathy. Though there are multiple studies carried out in the southern India, less data was available in the Middle Eastern Maharashtra. So we carried out the study. The aims and objectives of our study was to find out the risk factors associated with the development and progression of diabetic retinopathy, to study the prevalence of different stages, and to assess the visual morbidity due to diabetic retinopathy. First, we informed and educated all the patients about diabetic retinopathy, its signs and symptoms, and the treatment options available for it. We also inquired patients whether they were aware of the diabetic retinopathy as disease as such. And we also took the written informed consent from the patients. So it was prospective observational study. The study population was walk-in and referred non-diabetic patients in the ophthalmic OPD. The sample size was 102 and the study duration was 18 months. We included patients with diagnosed type 1 and type 2 diabetes, and also the patients with diabetic and hypertension. The patients who were critically ill due to diabetic complications, patients with media opacities, and patients who were not willing to participate in the study were excluded. So later, we inquired all the patients about detailed history regarding the duration of the diabetes, their treatment history, their previous ocular treatment history, also any systemic history, and then we carried out the examination for visual acuity and dilated fundus examination with indirect ophthalmoscopy, slit lamp biomicroscopy with +90 diopter, and we also took the fundus photographs. Then we diagnosed the patients for diabetic retinopathy, and according to that, we classified them for different grades. So these are some clinical photographs from the study. The first photograph is showing mild NPDR, that is non-proliferative diabetic retinopathy. It shows only microaneurysms. So the second photograph, it is showing moderate NPDR with microaneurysms and few dot blot hemorrhages. Third photograph is showing moderate to severe NPDR with dot blot hemorrhages, few hard exudates, and microaneurysms. The fourth clinical photograph is showing severe NPDR with cotton wool spots, dot blot hemorrhages, microaneurysms, and hard exudates. And the last clinical photograph is showing diabetic maculopathy with deposition of hard exudates around the macula. So coming to the results and discussion, in our study, we found out that majority, that is 87% of the patients were having type 2 type of diabetes mellitus. And we found out it was female preponderance, that is 55% of the patients were females. 60% patient had good glycemic control, and 48% of the patients were having associated hypertension with the diabetes. We also found out that 37% patients had deranged lipid profile. For majority of the patients were from the age group of 41 to 50 years, followed by 61 to 70 years, and 50% of the patients were having duration between 6 to 10 years of diabetes. 63% patients were affected equally with same grade of diabetic retinopathy in the both eyes. And patient with mild NPDR and moderate NPDR were having mild to moderate visual impairment. Patient with severe NPDR were having severe visual impairment, and patients with proliferative diabetic retinopathy were practically blind according to the definition of blindness from the WHO. Coming to the grades of diabetic retinopathy, so mild and moderate NPDR were affecting bilaterally, and severe NPDR affected unilaterally. Also, we found out that in moderate NPDR, there was maximum diabetic maculopathy incidence. We also found out that complications like tractional retinal detachment and vitreous hemorrhage in 5% of the patients. So coming to the conclusion, duration of the diabetes, then glycemic control, and associated hypertension and dyslipidemia were the most important risk factors associated with the progression and incidence of diabetic retinopathy. And we found out that moderate NPDR with clinically significant macular edema was most prevalent type. So in spite of having such a visual morbidity due to diabetic retinopathy, the patients were not aware of the disease entity. And so we need to at least to increase our screening, that is occasional screening for the diabetic retinopathy to prevent the visual morbidity due to it. Thank you.
Thank you so much. That was very nicely presented, and you've taken a very relevant topic, especially with Diabetic Day just around the corner. I was wondering, you mentioned that the age group of your patients was 41 to 50.
Yes, ma'am.
Is that around the age group you would expect to see a lot of diabetic retinopathy, considering that majority of your patients had type 2 diabetes?
No, ma'am. Actually, we were not expecting this type of age distribution, but because we are having a very rural population and the patients were negligent towards health. So when the patient is coming to our OPD, they were not aware of their diabetic status and also their visual impairment. So because of their negligence, we found out that most of the patients, because of their negligence to health and visual impairment, such age distribution might have occurred. Though we need more broader kind of study to evaluate this.
Okay, because I thought you had taken only known diabetics, but it appears you had patients who didn't know they were diabetic also. The other thing was you have taken type 1 and type 2 together.
Yes,
do you think that could have made a difference in your findings?
Yes, ma'am, because
so would it have helped? Would it have helped if you had analyzed type 1 and type 2 separately also? Maybe you would have got a different age predilection.
Yes, ma'am. If we would have taken separate type 1 and type 2 type of diabetes mellitus, in type 1, we get the diabetic retinopathy changes later, whereas in type 2 type of diabetes mellitus,
Sorry? I missed what you said. Could you just repeat that?
In type 1 type of diabetes mellitus, we get the diabetic retinopathy changes later because the patient is already on the treatment with insulin, and we screen the patients after 5 years of the diagnosis. And in type 2 diabetes mellitus, we should always screen the patient at the time of diagnosis, because the patient is not aware and the glycemic status may not be controlled. So in type 2 type of diabetes, the diabetic retinopathy changes could be earlier, before the diagnosis of the diabetes. So the age distribution and also the severity and grades of diabetic retinopathy will be different according to the type 1 and type 2 type of diabetes.
Okay, maybe when you present this as a publication, you could kind of analyze them separately also. That would help, yes, I think. Yeah. One more thing is, what screening schedule are you planning to put in for your patients now that you have done this study? Because you're dealing with a rural population. So how are you going to translate this study on the field?
Ma'am, we should ask the patient to follow up at least 3 monthly for the patients who are having mild to moderate diabetic retinopathy changes, and those who are having severe to proliferative diabetic retinopathy, we should immediately educate them about the treatment options available, because rural patients are not much aware of their visual impairment, and they may deteriorate.
Okay. One of the most important things of bioethics, why bioethics and not medical ethics, right? Yes, is where social justice becomes a huge component. Yeah. Yes. And when we say social justice, we are talking of people who are excluded from the normal healthcare system because of certain reasons, right? Certain inequalities, certain problems they have. Yes. I would suggest if you could consider a camp system, yes, which goes out into the rural community and kind of does some kind of basic monitoring there. I know everything cannot be done in the rural area. That may help in the area, because since we are on a platform of bioethics, we also need to consider the social justice of telling them to come every 3 months.
Yes, ma'am.
So that would be good. But great, and congratulations. Nice topic you have chosen. Very, very pertinent.
Thank you. Thank you.
Thank you.
That was a wonderful presentation, Dr. Shraddha. I'd like to tell you all that we only have 5 minutes for each participant and 2 minutes for buffer for questions from judges and audience. I request everyone to please make a note of it. Now I request Dr. Komal Gade to present her paper. I request her to share her screen. Dr. Komal, are you there?
Good morning, everyone.
Good morning.
So I am presenting the case, basically. It is a very rare case. It is a coronary cameral fistula. The patient presenting with the atrial fibrillation.
Sorry, Komal, to interrupt you. Please put on your camera.
Okay, sorry. Is it okay? Is it okay?
Dr. Komal, we're not able to still see you.
I've already started the camera.
This is your screen share. Can you touch your video and say start video?
Yeah, I've already started. I don't know why it is not starting.
I think we let her proceed.
All right, Dr. Komal, your time starts now.
Okay, Thank you so much. So I am presenting the very rare case, the coronary cameral fistula, presenting with the atrial fibrillation. So this is the case of 20-year male who was a resident of Nerul. He came with the complaints of palpitations since 2 days, which was fast, irregular, and present throughout the day, associated with the chest pain, which was intermittent, not radiating, associated with the breathlessness, the NYHA classification of 4, which was associated with orthopnea and paroxysmal nocturnal dyspnea. So there was no history of pedal edema, abdominal distension, fever, cough, cold, no episodes of bluish discoloration in the childhood. But after repeated asking, patient gives the history of some cardiac disease in childhood, but the details were not available at that time. On examination, patient was conscious, oriented, pulse was 180 per minute, irregularly irregular, variable in force, volume, bilaterally equal pulses felt all over. There was no radiofemoral delay. Apex pulse deficit was 40. BP was 90/30 in left arm supine position. JVP was 10 to 12 centimeters of water. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. On cardiovascular examination, on inspection, apical impulse was seen below the nipple lateral to mid-clavicular line. No scar sinuses. On palpation, apical impulse was felt in 16 intercostal space, 1.5 centimeters lateral to mid-clavicular line, and was hyperdynamic. On auscultation, S1 was soft. There was wide split of S2, and there is pansystolic murmur heard over mitral area with the continuous murmur heard over mid to lower sternum on the right side of the sternum. Respiratory system, there was bilateral basal crypts were present. On investigation, the routine investigations were within normal limit, the CPC, RFT, electrolytes, total Billy, thyroid function test, NT-proBNP was thought on higher side, 5,632. On chest X-ray, there was cardiomegaly present, and on ECG, there was atrial fibrillation with the rate of around 150 to 180. And there was poor R-wave progression with the right axis deviation. So after all this, we were thinking of the patient could be a rheumatic heart disease because the presentation was in the young age. But we did a 2D echo and we found something else, which we were not expecting. What we found was there was global LV hypokinesia, EF of 15 to 20%. There is 5 millimeter connection, which was seen between right coronary artery and right atrium with the continuous blood flow, and which termed as a coronary cameral fistula. There was moderate MR, mild TR, mild PH, and there was right ventricular dysfunction. So after looking at these echo findings, we diagnosed the patient as a congenital heart disease, that is coronary artery fistula, with the dilated cardiomyopathy, with the atrial fibrillation, and in congestive cardiac failure. So after that, we managed patient with following measures. As patient was in atrial fibrillation with the heart rate of 180, we gave the preference to his rate control. As patient was in failure and had a hypotension on presentation, we controlled the rate with the injection of digoxin 0.25 milligram. Then decongestive measures were given. Diuretics were given with the monitoring of his BP. He initially was on inotropic support. So we gave him diuretics according to his BP. He was started on anticoagulation with the injection heparin. Patient were given antibiotics. Then after confirming diagnosis of coronary cameral fistula with the 2D echo, patient was shifted to cardiac ICU. After that, he was planned to undergo CT coronary angio, but patient was not able to hold the breath. Patient directly shifted to cath lab, and he underwent diagnostic as well as therapeutic procedure under the cath lab. He underwent percutaneous transcatheter vascular plugging by using the Amplatzer vascular plug. And after that, patient has tolerated the procedure well, and patient was symptomatically much better, and he was discharged after that. So after presenting this case, I want to discuss this case. So what is this coronary cameral fistula? This is basically a rare entirety characterized by the abnormal communication between coronary artery, and it can be either with the cardiac chamber, then it is labeled as a coronary cameral fistula, or it can be with the systemic or pulmonary circulation, where it can be it is said as coronary arterial or venous fistula. It results from the aberrancy from normal embryological development. It is very rare. Incidence is 2 in 1 lakh population. It comprises around 0.2 to 0.4% of the congenital heart disease. So anatomy, there is normal 2 coronary arteries originating from aorta and they are taper progressively as they branch to supply myocardium. The fistulas arises as a persistence of sinusoidal connections between lumens of primitive tubular heart that supply myocardium. So this because of this fistula, there is bypass of myocardial capillary vessels. So there is less blood supply to myocardium. Major sites of origin are right coronary artery, left anterior descending artery, and circumflex artery. Major site of termination is right-sided changes. As we saw in our case that there is right-sided communication between right coronary artery and right atrium. A pathophysiology behind this is all hemodynamic changes in fistula depends upon the size of the fistula, resistance of the fistula's communication, and site of termination of fistula. There is high pressure coronary blood flow drains into low resistance venous circuit, bypassing of the small arterioles and capillaries of the myocardium. Because of this bypass, the coronary blood flow, because of bypassing of this coronary blood flow, it causes coronary steal phenomena, which leads to angina, MI, arrhythmia. The left to right shunt causes increased blood flow to right-sided structures, and that causes pulmonary hypertension and volume overload in both the ventricles. If left untreated, it can lead to high cardiac output failure. Etiology being this.
Last 1 minute left.
Okay, etiology is congenital, and then trauma, invasive procedures. Patient presentation is mostly asymptomatic, but can be presented as angina, MI, arrhythmia, as in our case patient presented with atrial fibrillation. Complications as hemopericardium. So management depends upon the size of fistula, presence of symptoms, anatomy. Small asymptomatic fistulas get spontaneous closure, and it can be managed with antiplatelets, antibiotics. When to go for surgical procedure when there is large fistula, irrespective of presence or absence of symptoms, or small to moderate fistula with symptoms. Treatment options are 2, surgical or percutaneous. Surgical ligation is done in cases of large symptomatic fistula and multiple communication. Okay.
Ma'am, your time is up. We're really sorry, but we need to cut you short.
My presentation is almost over.
Yes, ma'am, but your time is up. So, Dr. Shimpa, ma'am, would you like to ask her questions now?
I just wanted to know, you said the patient could not hold the breath, so you did not do a CT angio. Did you have any other options?
Yes, ma'am.
Did you have any other option that you could have chosen if the patient was unable to hold the breath and you couldn't get a CT angio? Did you all consider anything else?
Only options available are 2D echo, and then we can go for angio, like catheter.
Okay. Multi-slice spiral CT is usually ideal for these patients. Why are you calling it cameral? Why are you calling it coronary?
Because it is cameral is a synonym for cavity. So because right coronary is communicating
that's an
with
interesting piece of information.
Yeah, because cameral.
That's good. You mentioned in the management you're giving antibiotics. Can you tell me why?
Basically, ma'am, in patient was in failure, and patient in like government setup, and because of that we gave him a for prophylaxis, not for therapeutic. Patient was admitted in ICU, but that to prevent the infection, hospital-acquired infections.
Let me give you another hint.
Okay.
These patients, do they have any other complications apart from the typical ones you said? Aneurysmal bleeds in the hemopericardium.
Infective endocarditis.
Yes, should have mentioned infective endocarditis.
Yeah, infective endocarditis.
That is one of the commonest problems in our country, no?
Yes, ma'am.
You even put it in the treatment and you don't mention it in complications. You should remember. What other congenital disorders would you look for in this patient?
Another thing is there could be a anomalous origin of a left coronary artery from the pulmonary artery. That can also mimic this presentation. Then some coronary artery ectasias. Then some pulmonary patent ductus arteriosus, which can also present like this continuous murmur.
Patent ductus arteriosus? Okay. Hypoplastic left ventricle, pulmonary hypertension. There are a lot of congenital disorders that are associated with this. patients need to also, we need to keep that in mind. But excellent, very nice, rare case, unique. Yeah, so congratulations.
Yes,
what a lovely experience at a very young age.
yes, ma'am. Yes,
Okay,
yeah.
Thank you so much.
Okay. Thank you so much, ma'am.
This was Dr. Divya, am I right?
This was Dr. Komal, ma'am.
Dr. Komal, okay, the first child. Okay.
Yes, ma'am. All right. So just before we go ahead, guys, I would like to make a small announcement. We have another moderator coming in from Israel for the next session. Since we began the session a little late, we will stop this at 11:30 and continue after some time. We'll inform this on the group. So we sincerely hope that you guys will be able to make it. And ma'am, we can go ahead with the next speaker, ma'am, now.
Go on.
All right. So, Dr. Divya, are you here?
Yeah. Yes.
Okay. Dr. Divya, the floor is yours.
Yeah. Myself, Dr. Divya Shulke. I'm a third-year medicine resident at LTMJ SAR. I'm presenting a rare case of co-occurrence of methemoglobinemia and G6PD deficiency. So,
Dr. Divya, could you please share your screen?
Yeah. So,
Divya, time starts now.
So, 32-year-old male, chronic alcoholic, presented with complaints of low-grade fever without chills since 2 days, yellowish discoloration of eyes since 2 days, and passage of cola-colored urine since 2 days after taking some medication prescribed by a general practitioner, and breathlessness and easy fatigue since 2 days. On examination, his BP was 90/60 millimeters of mercury, respiratory rate was 28 per minute, and his saturation was 88% on room air. There was severe pallor present and icterus present. We did his ABG, which was suggestive of metabolic acidosis with normal PO2 and saturation was 99. So on pulse oximetry, saturation was 89%. On ABG, it is 99%. So saturation gap was present. His methemoglobin level was 20%. It is normal, it is less than 1.5%. And oxygenated hemoglobin level was 68.1%. We did his CBC, which has his hemoglobin of 3.2 and his RFT has creatinine of 5.0. In LFT's total bilirubin was 3.2 and the indirect bilirubin was 2.0 milligram per deciliter. And his OTPT was slightly raised. His serum LDH was 5,160 units per liter. So it was quite high. We did his urine for him HB, which came positive, and G6PD level was 4.6, which was on lower side. So this is the color of the blood that we withdraw from the patient. It was dark brown in color, and this is his urine bag, which is filled with the urine, which is cola colored, dark brown in color. So our clinical impression was it was a case of acute intravascular hemolysis with methemoglobinemia in case of G6PD deficiency, which causing acute kidney injury secondary to pigment-induced nephropathy. So what is methemoglobin? Methemoglobin is an oxidized form of the hemoglobin with changed heme configuration from ferrous to ferric. And this form of the hemoglobin, it doesn't bind to the oxygen and can't deliver the oxygen to the tissue. Besides that, it also hampers, it also increases the oxygen affinity between the normal hemoglobin and the oxygen. So it causes the shift of the oxygen dissociation curve to the left. Now, how this methemoglobin form in our body? It forms by the reactions with endogenous free radicals. Plus, there are some exogenous chemicals can also increase the methemoglobin either by directly or by indirect generating the free radicals. Reductions of methemoglobin. Now, this methemoglobin which is formed in our body, the level of the methemoglobin are kept on lower side by the certain enzyme system, one of which is RBC's enzyme like cytochrome B5 reductase, the deficiency of which can cause the congenital methemoglobinemia. Another pathway is NADPH metheglobin reductase and G6PD. This is an alternative pathway. It uses the enzyme NADPH metheglobin reductase. And here the electrons are derived from NADPH. NADPH is generated in HMP pathway by a G6PD enzyme. So, and in this path, there is no electron acceptor present in the RBC to interact with the NADPH. So this pathway is only activated by the extrinsic electron acceptor like methylene blue and riboflavin. And this explains the association of G6PD deficiency and the methemoglobinemia. Other pathways like the compounds like ascorbic acid reduce glutathione and riboflavin, they are also helpful in reducing the methemoglobin level. So there is a bedside test by which we can differentiate it whether it is a deoxygenated hemoglobin or it is a methemoglobin. Like as we, if we put a drop of blood on paper, so if on exposure to the air, normally the deoxygenated hemoglobin will become red because it combines with the oxygen. But since the methemoglobin level doesn't bind to the oxygen, it remains still brown. So this is a simple bedside test by which we can diagnose the methemoglobin. The management the management is usually include just discontinue the offending drug or medication. Supportive care include hydration, hypotension, ventilatory support for if any respiratory compromise, treatments targeted to neurological complications. Now, for the individual where methemoglobin level are more than 30%, or those with level of 20 to 30%, and who are symptomatic, especially if they have any underlying cardiac or pulmonary disease, we use the methylene blue for them. Methylene blue, it acts faster than ascorbic acid and thus is the treatment of choice for the symptomatic acute toxic methemoglobinemia. But there are two important contraindications for methylene blue. One is G6PD deficiency. Because if we use the methylene blue in such cases, it itself can precipitate the hemolysis. And the second is individual receiving the serotonergic agent because there is a risk of serotonin syndrome in such patient. So in our case, since the patient was having ongoing intravascular hemolysis, so we did the G6PD level, which came on the lower side. So we avoided giving methylene blue to this patient. The patient was treated with high flow oxygen, hydration, blood transfusion was given in view of anemia. We gave him vitamin C, injectable glutathione, and he also received the hemodialysis in view of AKI. We monitored his serum methemoglobin level and creatinine level. And the final outcome is gradually the patient's hemoglobin becomes stable. Creatinine decreased to normal, and initially he was in ICU, then later on he has been transferred to general medical ward and then later on discharged. And the patient is asked to avoid the drugs precipitating the G6PD deficiency. Normally we do the G6PD level after the 3 months of post transfusion. So our plan was to repeat his G6PD level after 3 months of post transfusion. Thank you.
Okay, thank you so much. This is one of those cases you don't see every day, especially when you're talking of congenital methemoglobinemia. We are more used to seeing acquired methemoglobinemia. You mentioned you gave the patient high flow oxygen. Can you tell me what is saturation gap? Have you read anything about saturation gap?
Yes, ma'am. On pulse oximetry, his saturation was 89%. But when we did his arterial blood gas analysis, the normally his PO2 was normal and his saturation was also normal. So that is the saturation gap was there.
What is the cause of this saturation gap?
Ma'am, because of that pigment, it might be by pulse oximetry. It is not able to measure the actual level of the oxygenated hemoglobin.
So does it measure a high level or a low level?
It measured low level of oxygenated hemoglobin.
Okay, this is where it's important to know. You will have low levels of oxygen because of methemoglobinemia. Okay, yes, but even that is an elevated indication of saturation. Clear? So because I have methemoglobinemia, I'm not showing 98, I'm showing 90, but I don't have 90, I probably have 85. Are you with me?
Yes.
There is an inverse relationship between the methemoglobin concentration and SpO2.
SpO2.
Okay. Okay. Tell me one more thing. What are the acquired causes of methemoglobinemia? Anything you can think of?
Ma'am, because certain chemicals can cause methemoglobinemia, like certain drugs can. Like road.
Okay, no problem. You have
tar
presented a
industries and
congenital
all.
case, so it's all right. Yeah, no problem. Okay, thank you. Thank you, Divya.
Thank you so much, Divya, for a wonderful presentation. Now I request Puta Yukta to share her screen.
Are you able to see my screen?
Yes, go ahead.
A very good morning to the esteemed judges, fellow participants, and the lovely audience. I am Yukta, a final year medicine student. Today, I would like to present a case report which highlights patients' autonomy and ethical considerations in psychosis. This is the case of a 43-year-old male with history of abnormal behavior from the past 2 years. He had delusions and the patient has completely lost insight and believes he is mentally sound and does not need any kind of treatment. He even attempted to stab his wife because of his persecutory delusions. Such cases are very commonly faced by psychiatrists, and these are very challenging situations to psychiatrists because while treating such cases, they may not always abide by the Mental Health Act 2017, about which I will be speaking about in a minute. Introduction. Psychosis is characterized by delusions, and delusions, hallucinations, catatonia, disorganized behavior, and negative symptoms. Around 1.5 to 3.5% of people are suffering with psychosis. Delusions are false, fixed beliefs which are out of keeping with the patient's educational, cultural, and social backgrounds, and the patient believes in this very strongly despite being contradicted by reality or rational arguments. Psychosis can be highly distressing to both the patient and his loved ones. It is the hallmark feature of schizophrenia spectrum and other psychotic disorders. The Mental Health Care Act 2017 aims to protect and promote the rights of patients and ethics during mental health care. This act promotes patients' autonomy and provides a choice for those with ability to make decisions on mental health care independent of the level of risks and complexities. However, in countries like India, most patients are not aware of concepts of nominated representative and advance directives, and as a result are not able to avoid involuntary admissions. At times, psychiatrists must compromise and violate the patient's rights for the patient's own sake. I present to you a 43-year-old male who is a high school dropout, who belongs to Hindu religion and a low-income family. Psychiatric interview revealed that he has often been suspecting his family members that they're trying to kill him from the past 2 years. He had delusions of persecution, and as a result, he believed his wife poisoned his food and tried to stab her. Along with this, he had delusions of grandiosity and thinks that he is the reason for sustaining all humankind on the earth and that he can control the universe. Based on psychopathology, according to International Classification of Diseases 10 guidelines, we made a diagnosis of psychosis, NOS. We admitted the patient as supportive admission and treated with antipsychotics over 2 weeks, and he slowly improved and got partial insight. However, as soon as he gained partial insight, he demanded for discharge without proper improvement in his thoughts. Abiding by the rules of MHCA, the psychiatrist should discharge the patient respecting his autonomy. However, we can't do that in this case because family members were already suffering with a huge caregiver burden. He was administered injectable medicines initially as he denied any oral medication. After a few days, he got convinced and he started taking oral medications. And he was given tablet olanzapine 5 mg and the dose was increased to 15 mg over a week. Tablet clonazepam 2 mg was given in divided doses and it was slowly tapered over a week. Trihexyphenidyl tablet 2 mg was given daily to prevent adverse effects from olanzapine. He improved well over 3 weeks and got discharged with full insight. He even agreed to take medications until the course gets completed, and he was willing to attend follow-ups. Moving on to the discussion. A nominated representative is a person or relative to the patient appointed either by the patient or the review board, and he can take treatment decisions for the patient during the course of treatment and during the periods when the patient is incapacitous to make sound decisions. An advance directive is the right to treat the patient as he likes to be treated. This is made in writing, and this is actually made when the patient is capacitous of making sound decisions. And in the advance directive, it is mentioned in writing how the patient wishes to be treated, who he appoints as the nominated representative. And a decision by the nominated representative is restricted to those with incapacity for mental health care decisions. In recent Mental Health Care Act 2017, there is a confusion regarding certain scenarios. For example, when the patient regains full insight after treatment, he does not want to take treatment, he wants to live like that, and he demands for discharge. Now, this can be because either the patient does not want to finish the course of treatment because he believes he's mentally sound and he doesn't want to deal with the stigma that follows afterwards, or he does not want to put an extra financial burden on his family or an extra caregiver burden. So in cases like these, there is confusion as to how to proceed. And there is a dire need to understand situations like these and make amendments wherever needed. In countries like India, there is very scarce mental health awareness, and there's also a lot of stigma surrounding mental health. It is important to avoid involuntary admissions and protect the patient's autonomy as much as possible. Every psychiatrist should consider both the family member's caregiver burden and treating the patient without human rights violation. Thank you.
Okay, Yukta, thank you.
Thank you, ma'am.
You have taken a very, should I call it a social point topic of discussion, since you are focusing on social justice and the rights of the patients who are in the vulnerable group. Just one question. Are you familiar with a term called substantive justice? And if you are, what is it?
Substantive justice is one of the core ethics of medical practice, ma'am, wherein we focus on providing justice to everyone. I mean, to all classes of the society.
Okay. Are you familiar with the terms of individual and collective justice?
Yes, ma'am. This is we focus on one individual's rights, and we respect their the privacy and rights of one individual, whereas collective justice is focuses on a more broader population.
Okay. Thank you.
Thank you.
Thank you so much. So we have a keynote at 11:30, from 11:30 to 12. So I request all the participants to please join at 12 p.m. Thank you, everyone. I request the judges to please be present at 12. And thank you so much, ma'am, for your time. Thank you.
You're welcome. See you at 12.
Hello. Good morning from Israel. I have a session, a lecture from 8 o'clock our time in Israel. Sharma.
Hello?
Yes, hello. Can you hear me, please? I have a lecture from 8 o'clock Israeli time.
Yes, ma'am. We can hear you. We welcome you, ma'am. For our participants, I will just like to inform them that we have Daniela Khedar ma'am with us here today, and she is from the International Center for Health, Law and Ethics, Faculty of Law, University of Haifa, Israel, and she will be giving her keynote on ethical dilemmas in the COVID-19 era. Thank you so much, ma'am, for joining us.
Okay, I will wait till 8 o'clock. Thank you very much. Yes.
Why did we start late?
Daniela, ma'am, we can begin whenever you're ready.
Okay.
Yeah.
I'm ready.
Okay, ma'am, sure. Like if you would like to screen share, I think the settings have been enabled.
No, I don't have any presentation.
Okay,
You
ma'am.
know, I just speak without any presentation, so I don't need the share screen.
Sure, ma'am, no issues.
Okay. Just a minute, I just close the door. There. Close the door in my room. I'm here with you. I'm here with you. Can I start?
Yes, ma'am, you can start.
Okay. So, good morning, good evening, afternoon, whatever you are, the audience all over the world. In Israel, it's now 8 o'clock, and I'm very pleased, happy, and honored to be with you. My subject is ethical dilemmas in the COVID-19 in this era. So when I thought about my lecture, I felt that I am here with a lot of responsibility towards you and towards the subject. Why the responsibility? Because maybe that I will speak, and in few minutes, what I will say will be less relevant. Why? Because we really feel a lot of uncertainty, a lot of rapid changes, a lot of suspicion, And the properties of this era, of the corona era, is those marks that I said. Because every minute, every hour, every day, we hear something else. And the uncertainty and the suspicious that I really mentioned is a part of our everyday life since the corona started. It's the uncertainty in the personal area, interpersonal relationship, social relationship, politics, medicine, feelings, cognition, behavior. Let's say that we change, the world change, and the questions that we raise every day in everyday life is what to do, what to think, what to feel, because the information, we have so much, a lot of information that sometimes we are really confused. We don't know what to do, to whom to listen, what to say, what to think. So the side effect and the result is that really that we feel that something shakes us every day. So the same is about the ethical dilemmas that we share in the medicine and everyday life, but in treatment. And the COVID-19 forces us to deal with ethical and bioethical dilemmas in the interaction between the individual and society, and between one and one's neighbor in all areas of life. Education, medicine, law, economic, sports, culture, parenting, family, society, and more. The dilemmas concern challenging and critical issues that affect the design of society and the individual, the benefit of the individual versus the benefit of society. Relativism and subjectivism versus social order and uniformity. Autonomy versus consideration of benefit and harm. Freedom of health versus controlled health, etc. We all felt those dilemmas. When we have older parents and we wanted to visit them, we ask ourselves, it's right to visit them because they are alone and they felt loneliness, and the damage was very high, not to the health, but not to the physical health, but to the spiritual health. So what to do? To visit them, not to visit them, to stay at home. So as time goes by, the virus floats above the fabric of our lives. More and more ethical dilemmas are added, some of which have existed almost since the dawn of humanity, but take on a different ground and depth, and some are new and seemingly new. In this lecture, my dear audience, I have chosen to focus on two key ethical principles that are reflected in almost every moment of our personal and professional lives: autonomy and personal responsibility, and benefit and harm. UNESCO's Universal Declaration of Bioethics and Human Rights state that autonomy to make decisions will be respected as long as the individual assumes responsibility for his or her own decisions and respects the decisions of others. We all felt it. We all felt that the autonomy to decide is different now in the Corona time that it was in the past. Because if I want to, today I have a lecture in another part of Israel, and I have to really think about those others who I will meet, to make some checks about the Corona, to take the mask, not to touch, not to be closer to the teachers, because I have today some section with teachers and children. So it's a different mind, a different thinking, a different behavior. The autonomous person controls his or her thoughts, is not driven by authority external to him or her, and has the ability to think independently and critically. Kant argued that the autonomy of individual is achieved through his or her intellect and self-selection of the laws of morality, and not through reckless response to external dictates. Human freedom exists, therefore, only when it is the source of one's decisions. If this idea is stretched, the more intelligent people become, the freer and better society will be for human beings. Is it so now in the area of Corona? I don't think so, because what I felt and what the doctor felt and what the patient felt and what the team felt, that we are not having anymore any autonomy or less autonomy to decide. Regarding benefit and harm considerations, the UNESCO Declaration states that in the application of scientific knowledge, medical care, and related technologies, the benefit of patients and the environment, both direct and indirect, must be examined, and the harm caused to them must be minimized as much as possible. Although it is easy to agree with these definitions, it is the wording of connect that creates dilemmas and challenges. It seems that with the oppressive existence of the virus, more and more autonomy is being robbed from the individual. Personal discretion is bound by rules and dictates based on decisions of the government, the Ministry of Health, the National Security Council, and various other bodies and institutions. Beyond, in addition to the unimaginable direct and indirect health, physical and mental, and economic damages caused to the individual and the state as a result of stopping the wheels of economy, many lose their autonomy to decide their own way. When somebody has to choose, one of the inability to choose how to treat, what to do with a patient. For example, the oldest patient, the autonomy, I think, in Israel really was taken from them because they couldn't meet the family. They couldn't go wherever they want to go. And the dilemma was, what can we do with those who are really suffering of being alone and feeling loneliness? We wanted to protect them, and the doctor wanted to protect them in the physical way. They wanted to protect their health. But when they couldn't see the family, and it was sometimes for 1 year, because in Israel, 1 year and 1 year and a half sometimes, and they felt so lonely. So also we damage not just the physical health, but the mental health and their feelings, and what really they felt was so hard. So the damage was so huge that we really think that the health was damaged, the mental health and the physical health. And those who has not any choice to decide from themselves or to really see what will be in the future, because those older people thought that they were neglected because they couldn't really have any say in the wide society. In long run, they also couldn't go to have a treatment and nourish the body and nourish the soul. And as we say, we know that healthy body and healthy soul go together. We have to really be very careful when we divide the soul from the body, because we know that the dialogue between healthy body and healthy soul goes together. And I felt that those people and those eldest people who really couldn't have not the autonomy to decide what to do, and the doctor really decided for them that they have to be isolated from the family or the society. It's a very huge and high ethical dilemma. So it's a very, it's very dramatic when you see how those older people suffer. Another ethical dilemma is the relationship between the caregiver and the patient. And the relationship changed because it is now in another way. In another way, the treatment has another direction. For example, the distance, the physical distance and the emotional distance between the caregiver and the patients. And the patients felt that they are also sometimes neglected because they don't really have the opportunity to have the real care. In Israel, sometimes caregivers gave a treatment through the Zoom, like I speak with you. And the Zoom was okay, but it's not enough because face-to-face meeting, face-to-face treatment have another direction and dimension of really just to hear the patient speaking and give some information. The neglection of the soul in treatment was very high in Israel. And I spoke with some patients, and I really felt that they're really in high tension, because I heard some saying for a patient that he said, okay, I can tell the doctor what I feel, but the doctor cannot see how I feel. He cannot see my expression in my face, really. He cannot really see my eyes speaking. He cannot feel my stress. He cannot feel my feelings. He cannot feel, the caregiver cannot really see me. As a human being, he can see my disease, but he cannot see my soul. So what to do? It's really an ethical dilemma, because one of the most important things in treating patient is to be close to a patient, is the empathy, the sympathy, the sensitivity, the communication. And the communication was very strict, very instrumental, very informative, without sometimes any soul from the doctor to the patient. And they felt that not just the autonomy was taken, but also the relationship, that's so important, the relationship with the soul, with feeling, with emotion. The emotional relationship was taken. And I cannot say to the doctor, please see me. I cannot say it, because we really don't know what to think. We really don't know what to say. We just want to have a solution to our problem. But in the subtext, the part of the solution is not just the treatment, but is not just what, but is also how. And the how was taken from the soul of the relationship between doctors and patient. The closeness of the physical, of the physical treatment was damaged. And it was, in Israel, they said from the Department of Health to avoid close relationship, not to shake hands, not to be close. And we know that a part of motivation of healing is when the doctor really is close also with our feelings and our emotions. Another thing, that because of the corona, some of the treatment really were stopped, and some of the treatment, as I told you, was through the Zoom. So the distance, the physical distance and the emotional distance damage also. And when I speak about benefit and harm, the benefit was that we really, the doctor really were save, the time, and sometimes they really treat the patient with the thinking about the health and security of the patient. But the harm was very high in the emotional level. Also, the treatment of children. The treatment of children were also damaged because in the everyday life, the children really felt more suspicion, and they were afraid because they don't have any emotional care from the doctor. So the thinking about damaging and harm was much more fragile than in everyday life. So we want to live in some harmony, and we want to have some ability to choose our way. But as in a personal way of telling you and a personal way of thinking, I felt that my possibilities in in really decide in an autonomy way and to choose my way was damaged. The doctors felt the same because they were more rule in treating the patient. And sometimes, you know, one doctor told me, I just wanted to hug my patient. She was a very dear patient to me. She had cancer, and I just wanted to comfort her and to give her some feeling of security, and that she will know that I'm here for her, and I couldn't do it. And then the patient asked him, Doctor, can you please hug me and just tell me what to do? And the doctor said, no, I am very sorry, I cannot do it. You are far away from me. I have not the autonomy to decide to do it, and the damage of doing it to you maybe will be more than the damage of not. And the doctor just looked at her and he said, I am with you. My heart is with you. My soul is with you. But I have no the autonomy to decide what to do. Another treatment with the ECMO, also to decide where to give and when to give, to whom to give the ECMO treatment, to the old patient, to the critical patient, to the young patient. We have a lot of problems because we have not enough ECMO when the corona was in the high level. And we really felt, I think that the doctors sometimes felt that they cannot do anything. They felt very helpless in their decision. They sometimes felt very helpless in really solving those problems in everyday treatment. And the corona changed it. It changed it in a very huge dimension of looking in the autonomy and doing harm and benefit and harm. So the treatment, the dilemmas of bioethical dilemmas in Israel and all over the world, we have it every day, every moment. And we know that we have to decide now, and the doctor have to decide in another way of looking on the medicine and looking on the patient. Maybe the doctor and, you know, the doctors and the caregivers have to really learn and to take into account the metacognition, another way of thinking on medicine, another way of thinking of treatment, in the thinking, in a high level of thinking, and to take into account that we have the ability as very intelligent person and caregiver and doctors to give some maybe lessons in metacognition and high level of thinking, and also to take into account the way that we feel toward some treatment and some decision. And one of the very effective tools is the emotional intelligence in treatment. And the emotional intelligence in treatment, the dialogue between thinking, feeling, and behaving must be in a very wide sense of the treatment, because it gives us another dimension of how to treat, when to treat, what to say, what is the autonomy. Can we really be much more flexible in doing things? Because Darwin said, you know, those who survive are those who really can endure and solve the changes and be flexible. So one of the things that it's very important now in taking into account the autonomy and doing harm and doing benefit and harm bioethic dilemmas is the flexibility that we have to take into account in solving bioethical problems. It's not black or white, it's gray. And we know it as doctors and caregivers, because dealing with human beings, dealing with people, takes into account the changes and the rapid changes that we have to deal with. So I hope that the corona will finish, okay. But one of the psychologists in Israel said, maybe the corona will go away and we will not have it anymore, but the side effects of the corona will stay with us long time, because we are not just human being who think, we are human being who feels. And what we felt is very important in everyday life. As Maya Angelou said, the philosopher and the American philosopher in 1951, people will forget what you say, people will forget what you do, but they never will forget what you cause them to feel. So I hope that I really succeed to give my side and my thinking about the bioethical dilemmas in benefit and harm and the autonomy. And I really think that we have to take it into account, and I wish you all best, and feel good, and have a nice day and nice lectures. Thank you very much to all of you. I know that you are a lot, and I prefer to see you and to feel you and really touch you. Touch you, I mean, with my soul, with my eyes. But thank you for the opportunity to be with you. Thank you very much.
Thank you so much, Daniela ma'am, for really sharing your insights on the kind of ethical dilemmas that have come up during COVID-19. And I'm pretty sure that a lot of us medical interns who have really worked for like COVID duty could really relate to everything that you shared. So thank you so much, and thank you for giving your valuable time for this session.
Thank you very much, and have a nice day. I'm going to teach now, and have a nice day. Thank you.
Good day, ma'am. Good day to you.
Bye-bye, bye-bye, bye-bye.
We'll now start with the remaining paper presentations for the day. So Shravya, are you here?
Yes, I'm here.
Yeah, you can take over now.
A very good afternoon, everyone. Now we'll be commencing with scientific paper presentation. Shimpa ma'am, Dr. Shimpa ma'am, are you there? I request all the participants to be ready with their presentation. We'll be starting soon.
Hello?
Yes, ma'am.
Am I audible?
Yes, ma'am, you're audible.
Hello, am I audible, Shravya?
Yes, ma'am, you're audible.
Okay. I'm just temporarily muting myself, but you all can start.
Yes, ma'am. Thank you so much, ma'am. Yes. So we'll commence the session. Now I request Ketki to go ahead with her presentation.
Yes, ma'am. Good afternoon, ma'am.
Yeah, good afternoon. Good afternoon, Ketki. Please go ahead.
Ma'am, my topic is airway management in maxillofacial trauma. I'm third year anesthesia resident from Lokmanya Tilak. First, the introduction part. The airway management of the patient with maxillofacial trauma is a very complex and crucial. It can dictate a patient's survival, and it is extremely difficult because trauma involves the patient's airway and their breathing is compromised. In this patient, the mask ventilation and endotracheal intubation are anticipated to be difficult. And many of these patients have a cervical spine injury. So there is a high chances of regarded as a full stomach and having increased the risk of regurgitation and pulmonary aspiration. In maxillofacial trauma, the most common airway injuries can occur is sometimes there is a posterior displacement of fractured maxilla parallel to the base of the skull may block the nasopharynx. Sometimes there is a bilateral fracture of anterior mandible so that it pulls the tongue to posterior and block the oropharynx of the patient. The fractured teeth, bone, any foreign body may block the anywhere along the oropharynx and nasopharynx. Hemorrhage or a soft tissue swelling may delay the airway compromise. Trauma to larynx or trachea may cause an increase the risk of cervical airway obstruction. My case scenario is there is a 22-year-old male with history of road traffic accident. He has a history of fall from bike, having a head injury, ear, nose, throat bleeding was present, and facial bone fractures are also present. His GCS was eye-opening is E1, motor movements V2, and visual is 1. The blood pressure was 100/60 millimeter of Hg, heart rate is 62 per minute, and saturation is 89% on room air. On auscultation, his air entry is also reduced on both sides, and pupil is right side sluggish, reactive to light, and left side constricted. On investigation, his CT brain was a normal bare brain parenchyma with bilateral mandibular fracture, and maxillary fracture was present on right side. And USG first is normal, not associated with disease. The immediate management was done is oral and nasal suction was done because he's having lot of ear, nose, throat bleeding was present, and neck stabilization was done. For a cervical spine injury, humidified oxygen therapy was given by face mask as his saturation was dropping to 89%. The patient GCS was poor, so decision is taken for immediate need for intubation. So endotracheal intubation was done to secure airway. In developing countries like India, the road traffic accident is the most common cause of injury. For maxillofacial trauma, others are flight and assault, sports and athletic injury, industrial accident, domestic injuries, and fall. Out of all the facial bones, mandible is the most commonly get fractured, then maxilla, zygomatic, nasal, and mandibular. When the patient came, the immediate management was primary survey should be done. First, see the ABCD protocol. A for airway maintenance with cervical spine protection. B for breathing and ventilation. Then C for circulation and hemorrhage control. Then control all the disability. And then last part is the exposure and environmental, including hypothermia, hypovolemia, hypoglycemia, and other investigation to be done, X-ray and USG fast. And later on for urinary catheter, nasogastric tube, blood workup should be done. Most of the patient associated with road traffic having ENT blades, so clear the blood and mucus product, give proper position to stabilize cervical spine, remove the foreign body. In case of bilateral symphyseal fracture of mandible, controlling of tongue position when voluntary control is lost. And give a simple airway strategy. Use chin lift, give a jaw thrust, 100% oxygen, and go for intubation, oropharyngeal or sometimes nasopharyngeal. If not possible, then go for supraglottic airway devices for inadequate breathing patient. The indication for definitive airway strategy is if the patient is unconscious or a severe maxillofacial fracture, risk for aspiration or a risk for obstruction. If the patient went into apnea, if he is having inadequate respiratory effort, for example, tachypnea, hypoxia, cyanosis, hypercapnia, or he is having any severe closed head injury. The options to aid the intubation are there may be a direct laryngoscopy, tracheal intubation, video laryngoscopy and intubation, fiber optic tracheal intubation, intubation with supraglottic airway devices, or nasal intubation. So patient is already airway compromise is there, so pre-oxygenate the patient with 100% oxygen, give us required pressure, then to avoid aspiration, then administer IV induction agent and scoline. It is a, and then go for, if the as a patient relaxes, go for tracheal intubation. It's a rapid sequence of intubation. Other method to secure airway, sometime because of the mandible fracture, there is a oral intubation is not possible. So sometime go for the submental intubation. In this, patient is intubated orally, then passage is created through submental portion when the ET tube is sutured in the place and giving a reliable and secure airway out of surgical plate. Second one is a retromolar intubation. Then sometimes these options are not possible. Then go for a surgical method to secure airway by tracheostomy. And fourth one is a nasotracheal intubation. But nasotracheal intubation is contraindicated in a patient having a skull base fracture or if the patient having epistaxis. These are the picture. First one is a submental. Second one is a retromolar. The third one is showing tracheostomies, and fourth one is for nasal intubation. This patient require if the in this patient the elective surgery for maxillofacial trauma can be planned 10 to 15 days after life-threatening emergencies are tackled. Patient require a high dependency unit for a post-operative care. In some cases, they may require early surgical intervention. For example, if the patient having injury involving ocular injuries, if the patient having ocular injury may require early surgical intervention, and endotracheal tube may be retained post-operatively till the patient is fully awake. Summary of this topic discussion is, in India, there is a high prevalence of a road traffic accident. Most of the patients are young male. Intoxicated males are more commonly involved. The base of skull and upper airway are closely related anatomically and having a clinical implications. So the anesthetic management of this patient with maxillofacial trauma can be a challenge. So they are a long surgical procedure and involve a significant blood loss. And airway patency is a priority in acute management for loss of airway. Loss of airway kills more quickly than any other circulatory problem. Thank you, ma'am.
Audible? No. Yes. Am I audible now?
Yeah, ma'am. Audible.
Yeah. All right. Thank you so much. That was very detailed and yes, a topic that has great relevance. I just wanted to know, you've spoken of all the different kinds of intubation, but at the primary site of accident, since we are talking of RTAs, what is the role of laryngeal mask airway?
Sometime ma'am, because of head injury or skull base fracture, sometime because of foreign body, immediate intubation is not possible. So we use supraglottic airway devices, which can be introduced blindly. So we can give an immediate with ambu ventilation, and you can increase the saturation of the patient. We can increase.
Yeah, but what is the role of LMA? You're not telling me that.
This is same ma'am. Sometimes intubation is very difficult in this patient because of cervical spine injury or any other. If the sometimes a trachea or larynx may get injured in this patient, the tracheal intubation is difficult. So in this patient, saturation is also goes on dropping. So for the immediate intervention before tracheostomy is also emergency, but we cannot do at the incident site. It requires time. So for a temporary basis, we can introduce laryngeal mask airways.
What is the role of LMA in terms of ease of intubation and post-intubation complications? Or post-patency, post-use complications? I'm talking only with reference to RTAs.
Okay. Ma'am, can you repeat question, please?
How do LMAs stand vis-a-vis ease of use and
it is easy
complications?
No, ma'am, it is easy to use, but most of the complications are complication. It does not seal the trachea properly, completely. So there is a chances of aspiration, but it gives a, but sometime for immediate basis, we can use.
Okay. Thank you.
Thank you, ma'am.
Thank you so much.
Thank you so much, ma'am.
Nice.
Now I request Dr. Ashish to share their screen.
Good afternoon to everyone.
Good afternoon.
Yeah. So I am hereby presenting a case report of a polycythemia vera patient who presented as a cerebral venous sinus thrombosis. So cerebral venous sinus thrombosis, although being multifactorial in etiology, is now being increasingly suspected and diagnosed. Its occurrence with polycythemia vera is rare. Polycythemia present clinically due to hypercoagulable state or an additional precipitating factor may bring the patient to the hospital. Hereby, in our case, the patient was case of chronic alcoholism who presented as hemiparesis and conversion with radiological imaging suggestive of thrombosis of multiple sinuses. So for introduction, a cerebral venous thrombosis should be considered as a differential diagnosis in all unexplained CNS disorders of sudden onset. It has a more prevalence in a female, the etiological factors being often subclinical forms of several common thrombophilic states occurring together rather than rare causes. Whereas a polycythemia vera is a clonal stem cell disorder in which the bone marrow makes excessive red cells, producing neurological problems in about 50% of the patients. It is more common in males. The symptoms are caused mainly by the increased blood volume and a thrombotic hemorrhagic complications. CVST has been associated with many hypercoagulable states like thrombocytosis, polycythemia vera, and remote infections. So our case is a 57-year-old married male who was a chronic alcoholic, a non-smoker who presented to the emergency room with a history of headaches since 4 days, followed by 2 episodes of conversion. He was apparently healthy prior to the illness. The patient was an alcoholic consuming around 180 ml of alcohol per day, every day for the past 15 years. The clinical examination revealed a right hemiparesis with a right supranuclear facial palsy. The pulse was 110 beats per minute with a blood pressure of 100/70 mm of mercury. There was no other significant abnormality. The other clinical system examination was also normal. On investigations, the patient's hemoglobin was found out to be 19.5 gram per deciliter with a hematocrit of 61%. The TLC was normal. However, the platelet counts were slightly on the lower side, 110,000. The INR of the patient was normal. However, the serum erythropoietin level was 2.77, which is a subnormal level, which indicates a primary cause for a erythropoiesis. His fasting sugars, blood urea, creatinine, lipid profile, and serum electrolytes were within normal limits. ECG and 2D echo were also normal. His CT brain venography revealed a superior sagittal sinus, a bilateral transverse sinus with a venous thrombosis, with a venous hemorrhagic impact, and a subarachnoid hemorrhage. A bone marrow examination was performed to look for the cause of erythropoiesis, which showed a hypercellularity for age and trilineage erythropoiesis, which is suggestive of a myeloproliferative neoplasm. A JAK-STAT mutation test was done, which was negative. With an elevated hematocrit, a low erythropoietin levels, radical evidence of thrombosis, and a bone marrow examination of suggestive of myeloproliferative neoplasm, the patient was diagnosed as a case of polycythemia vera. This is the CT imaging findings of the patient, which is showing a venous hemorrhagic impact in the high parietal area, where in the right side we can see a CT brain, which is showing a subarachnoid hemorrhage. Management: with a high index of suspicion, a hyperglycemic state such as polycythemia vera was thought to be the cause. After correction of dehydration, he was treated with heparin, hydroxyurea, levetiracetam, and a phlebotomy was performed. The patient had a satisfactory response to the treatment, and there were no episodes of seizures. His headache subsided, and he was comfortable. He was discharged 10 days after admission on tablet rivaroxaban, hydroxyurea, and levetiracetam with a plan to follow up with CBC to look for hematocrit on follow-up. So for the discussion, a CVST is not an uncommon cause of stroke in the country. Amongst variety of causes such as including dehydration, acquired and inherited prothrombotic states, local infection, or neoplasm can cause this. The common causes, the common manifestation of CVST are headache, papilledema, focal neurological deficit, and seizures. Polycythemia causes stasis of blood that results in hyperviscosity, which is a factor for classic virtual triad of thrombogenesis. The aim of treatment in CVST with polycythemia is to prevent further thrombosis by reducing the high blood viscosity. Phlebotomy serves initially to reduce hyperviscosity by bringing red cell mass to normal range. Periodic phlebotomies thereafter serve to maintain the red cell mass within normal range. Anticoagulants are indicated when a thrombus has been occurred, and a cytoreductive chemotherapy is recommended in patients with high thrombotic risk. Allogeneic bone marrow transplantation may be curative. Most patients with polycythemia vera, however, can be managed effectively without function impairment by phlebotomy alone. These are my references. Thank you.
Okay. Thank you so much. Interesting case. How common is cortical sinus thrombosis in polycythemia vera? Is it a very common presentation?
Ma'am, there are 2 to 3% incidence of venous sinus venous thrombosis in case of polycythemia vera, out of which the most common sites of thrombosis are either a Budd-Chiari syndrome or a mesenteric vein thrombosis. The occurrence of a cerebral venous sinus thrombosis is very less likely in case of polycythemia.
Yeah, okay. You said you will bring the levels down to normal. What is the level of RBC percentage hematocrit you want to reduce the risk of thrombosis?
Ma'am, around 45% is the target hematocrit we need to maintain in the patients.
You've given the patient hydroxyurea in this case. What were the options if hydroxyurea would not work?
Ma'am, the other option is an interferon.
Okay, anything else? Have you heard of any JAK inhibitors being used?
Yes, ma'am, I just cannot remember the reason right now.
Okay, okay. Ruxolitinib is used, but yeah, okay, thank you. Thank you so much.
Thank you, sir. Now I request Dr. Ajinkya to share his screen.
Good morning.
Good morning. Please.
I'm presenting I am Dr. Ajinkya. I'm from Lokman Tilak Medical College, third year medicine resident. Presenting a case of Osler-Weber-Rendu syndrome, a rare entity. This case report highlights the importance of investigation in case of suspected Osler-Weber-Rendu syndrome to avoid the catastrophic complications of this disease. A 38-year female resident of addiction presented with the complaints of the bleeding through nose since 3 weeks, weakness and easy fatigability and breathlessness on exertions in past 7 days. Patient is known case of the HIV diagnosed case with the ART treatment since last 10 years. ART treatment was TLE, which was changed to abacavir, lamivudine, atazanavir 2 years back. Patient had history of multiple admissions for the similar complaints of the bleeding nose and general weakness over last 10 years with history of multiple blood transfusions. For above complaints, patient was evaluated multiple times by ENT and medicine combined over the last 10 years. On previous admission, patient was evaluated. Okay. On inquiry, patient gives history of first episode of the bleeding in 1989 after delivering her third child, and a few minor episodes of the nasal bleed every 4 to 5 years after that, with increase in frequency requiring transfusion since 2008. On inquiry, her 28-year-old son also has few episodes of the minor epistaxis in last 5 years and in childhood. And one of the sisters of the patient had occasional nasal bleed. No history of fever, cough, cold, no history of vomiting, loose motions, no history of hematemesis, no history of syncope or loss of consciousness, no history of convulsion, no history of CVA, or no history of bleeding from any other side. Is right-handed, conscious-oriented, cooperative. Pallor was there. She was having spoon-shaped nails, multiple telangiectasis, dilated vessels on the oral mucosa, hard palate, lips, fingers, soles, and palms were noted. JVP was raised, no icterus, clubbing, lymphadenopathy, or edema. She was vitally stable. No arachnoidectomy, no slender fingers, normal joint mobility, no valgus or varus deformities of the joints. On investigation, her HB was found to have 3. Other cell lines were normal. Reticulocyte count was 6. Peripheral bone, peripheral smear was hypochromic microphatic anemia. Her MCV was suggestive of iron deficiency. Other stool OB was stool for blood was positive, and recent CD4 count was 276. HIV viral load was less than 20. ANA, TFT, other investigations were negative. So we investigated thoroughly for CT cerebral angiography, wide neck saccular aneurysm arising from the distal cervical segment of the left internal carotid artery was noticed. CT chest, mildly prominent pulmonary artery, and cardiomegaly was there. Abdomen and pelvis showed torsions of the descending thoracic aorta, aorta, focal outpointings in the
Have we
posterior
lost
branch of
your
the right.
presentation? Have we lost
Yes,
your?
ma'am.
Yeah, go on.
CT abdomen pelvis was showing intrahepatic saccular aneurysms and hepatic arterioportal shunts. Multiple torches intrahepatic collateral saccular aneurysm in the distal splenic arteries were noted. Partially calcified aneurysms in the mid pole of the right kidney, and a few intrahepatic varix or venous aneurysms along 7, 6, and 5 were noted. CT PNS was done. It showed deviation of nasal septum with the septal spur abutting the left inferior turbinate. 2D echo, her EF was 40-45%, no valvular abnormalities detected. Nasal endoscopy was done. Multiple telangiectasia over the nasal septum and the inferior turbinate with the DNS and sharp spur was noted. Upper GI endoscopy showed multiple telangiectasia in the lower esophagus, fundus, and body of the stomach. These are the images showing dilatations and aneurysms on the CT. Severe blood loss, anemia secondary to bleeding telangiectatic vessels in nose, upper gastrointestinal tract with multiple aneurysms in the liver, in brain, and positive history of the recurrent epistaxis, suggesting definite diagnosis of the hereditary hemorrhagic telangiectasia, also called as Osler-Weber-Rendu syndrome. We can think of some differentials like HIV-induced vasculopathy also, but this patient presentation was before she was diagnosed with the HIV. So, and she fulfills the more than three criteria for clinical criteria for HST. So we can label her as a diagnosis of Osler-Weber-Rendu. On discussion, Osler-Weber-Rendu syndrome is transmitted as autosomal dominant trait with varying penetrance and expression with the highly variable presentation among and within the families. Diagnosis is clinical with diagnostic criteria. Genetic testing for ESC, VRL1 or SMAD4 gene can be done, but it is not mandatory to do the genetic testing. affects blood vessels throughout the body, causing vascular dysplasias, multiple dilated vessels, and AV malformations. Recurrent severe epistaxis requiring blood transfusion is the most common presentation, with 90% of the patient presenting after the age of 40 years. Risk of catastrophic stroke to pulmonary cerebral AVM, excessive blood loss through the nasal or GI telangiectatic vessels causing severe blood loss, anemia, AV malformations leading to high output cardiac failures, venous thromboembolism, hepatic encephalopathy secondary to the hepatic arteriovenous malformation, and heavy GI bleed are the complications. Pregnancy with this syndrome is considered to be high risk pregnancy with mortality of 1 to 2%. We can treat this condition by correcting severe anemia with transfusion and iron supplement. Treatment of the recurrent epistaxis by humidification, packing, tranexamic acid, aminocapric acid, electrocautery, and laser ablation can be done. Treatment of the GI bleed by otoscopic airborne laser ablation. AV malformation with the high output cardiac failure embolization for the size of 3 mm or more, or IV bevacizumab can be used. In symptomatic pregnancy with the pulmonary AV malformation, diagnostic testing can be done with low dose non-contraceptive at any stage as clinically indicated, and treatment should start in second trimester unless otherwise indicated. Hormonal therapy is also mentioned. 50 microgram of ethylene estradiol and 1 milligram of norethistone resulted in significant reduction in transfusion requirement. Thank you, ma'am.
Okay, thank you so much. A very interesting case, and you've done a fantastic workup. Not only that, I think you were very lucky to get your clinical criteria so beautifully all over the place.
Yes, ma'am.
Question is, what are the complications? You found hepatic AVMs also, am I right?
Yes, ma'am, yes.
So what complications would you expect would fall out from here?
Hepatic AVM can cause hepatic encephalopathy as the large volume of blood can bypass the liver and directly go into the systemic circulation. So it can
large
cause
amount of blood bypasses the liver and goes into systemic. How will it affect the heart?
it also called high output cardiac failure.
Okay, so that it could cause high output cardiac failure. Then what else can it cause? Anything else you can think of?
Pulmonary edema it can cause.
That's high output cardiac failure, part of it.
Yes.
I'm talking of how the hepatic. Okay, tell me one thing. We typically talk of ablating these AVMs or thermal treatment, as you called it.
Yes.
Can we? How do we treat the liver AVMs?
For liver AVM, we can do coiling of the AVM using interventional radiology.
Can we do embolization?
Embolization we can do, that is also mentioned in the treatment. We do these invasive treatments only when the patients are symptomatic or patients are having complications. If patient is asymptomatic, we will just monitor and observe the patient.
Okay. I think that was a trick question. Maybe I shouldn't have asked it, but liver embolization is not recommended. Embolization is recommended everywhere else because there's a lot of necrosis and problem in the liver. Okay, always keep that in mind. Embolization for liver is a big no, but otherwise, very well worked up case. Thank you for presenting it. Thank you.
Okay.
Thank you, ma'am. Thank you, Ajinkya. I'll move on to the next presenter, Dr. Kapil. Dr. Kapil, are you there?
Hello, good afternoon, ma'am. Myself, Dr. Kapil, medicine resident from LTMMC.
Yeah.
I'm just not
Why
able
do
to.
we have so many medical residents from LTMMC presenting? Please give my regards to Dr. Nitin Karnik.
Thank you, ma'am.
Yeah, I don't know if you know, but I am an alumni of LTMMC. And Dr. Karnik was my lecturer, so please give him my regards.
Okay, ma'am. I will surely.
Yeah. Go on.
Just a minute, ma'am. Can you see my presentation, ma'am?
No, I think I can see your folder.
Okay.
Just click on to the presentation.
Can you see now?
Not yet.
Hello?
Sorry, Kapil, not yet.
Just a minute. Can you see now? Ma'am, now you able to see?
No.
I think you need to stop sharing screen, open your presentation,
Okay,
minimize it, and then start sharing screen again.
I will just.
Hello,
Kapil?
Shilpa ma'am. A very good afternoon.
Hi, good afternoon, Shubham. Nice to see you. Kapil, Dr. Kapil?
Yes, ma'am. Just a minute, ma'am.
First you stop, first you stop sharing screen.
I'll just stop my sharing. Just a minute, ma'am. And now you able to see?
Kapil, just open the presentation and then go to the presentation while you're sharing.
Okay, ma'am. I will just present after next candidate. After.
Okay. Okay. Now we'll move on to the next presenter, Dr. Shalini James. Please note, ma'am, Shalini.
Yeah.
Good afternoon, everyone.
Request Dr. Kapil to stop sharing. Yeah, thank you.
Yeah, good afternoon, everyone. Can I start presenting, Mona?
Yeah, you can go ahead, Shalini.
Can I start?
Please do.
Yeah, okay. So good afternoon, everyone. My name is Shalini. I'm currently majoring in Bachelor of Occupational Therapy and I'm an intern student. I'm here to do my paper presentation on occupational therapy in migraine. In the following slides, we'll be seeing about what is exactly migraine and how occupational therapy can be useful for treating migraine. Introduction. Migraine is one of the most commonly occurring type of headache that is listed under International Classification of Headache Disorders 3. It is often presented with severe headache and autonomic nervous dysfunction and even sometimes with aura. According to a survey conducted by the GBD in 2019, migraine is stated as the 6th most commonest medical condition in the world, and not just that. Migraine is also stated as the 2nd most disabling medical condition among women than in men. Evidence also suggests that migraine can negatively impact the daily functioning of overall quality of life. And being an occupational therapy student, this exactly led to the research focus on migraine, and the study title is A Case Study of Occupational Therapy for Improving Daily Performance in Migraine Patients. The aim and objective of my study is to improve the daily functioning of the migraine patient by providing occupational therapy and also to study the effect of it and the same. The purpose of my study is to identify the ways in which occupational therapy can contribute to treating migraine headaches and also to aid future research in formulating therapeutic models that can connect occupational therapy with migraine, which can be very useful in developing the occupational therapy goals and treatment process for the migraine. Moving on to the methodology, the ethical permission was obtained from the IEC of Shiva, and the informed consent was obtained from the study participant. The study participant was recruited based on the selection criteria, screening assessment results, and as well as sampling method. COPS, abbreviated as Canadian Occupational Performance Measure, was used as a pretest. Following that, a 12 session of occupational therapy based on migraine management was provided for the patient. And following that, COPM was re-administered again as a post-test measure. The pretest and the post-test data obtained from the COPM was then subjected to data analysis and interpretation. The research design implied in my study is single case experimental design, and the sampling method used is purposive sampling. The selection criteria of my study states that the participant should be within the age group of 18 to 65 years. The participant should have experienced migraine attack at least for a year. The participant should have a migraine frequency of at least 2 episodes per month. And the participant, if in case they are taking any medication for managing their migraine, then the medical regime should have not been altered in the last 3 months. And also the participant should not be suffering from any post-brain injury. The participant should not be pregnant. And finally, the participant should not have any comorbid psychiatric diagnosis along with migraine. The screening assessment used in my study is headache impact test 6. The data analysis was based on direct observation of change in the average scores of COPM pre-test and post-test. COPM is a client-centered measure, so the client will be asked to rate their own performance of their own ADL separately, and as well as the satisfaction on performing their own ADL separately. So in this graph, we can see that performance rating scale of COPM, the pre-test score was 5.25, and after intervention, the post-test score was 7.25. In the satisfaction scale of COPM, the pre-test score was 4.25, and after intervention, the post-test score was 7.75. The result was concluded based on a descriptive statistics given by COPM, which states that if there is a 2-point difference in the COPM pre-test and post-test, it's subject to performance and satisfaction scale, then it indicates a clinically significant change. And in the following graph of average score difference, we can see a 2-point difference between the pre-test and post-test of performance. And also there is a difference in 3.5 difference in pre-test and post-test of satisfaction. So this indicates a clinically significant change. Conclusion, hence the research objective has been met, and the results clearly indicate that there has been an improvement in the daily performance, and it can be concluded that occupational therapy can be an exemptional non-pharmacological treatment option for migraine. Recommendations. First, therapeutic model connecting occupational therapy and migraine is much needed, and applying the occupational therapy practices for other types of headaches listed under ICSP can be useful. And also investigation in the group management, occupational therapy group management for migraine can be really useful. My study was conducted under the guidance of Dr. S. Lognalin. He's one of the assistant professors of Department of Occupational Therapy at Srihar. My sincere thanks to Dr. P. Raghuram. He's a professor and HOD of Department of Occupational Therapy, Srihar, and he's also the convener of the Tamil Nadu All India Branch of Occupational Therapists Association. And also to Dr. T. Sundaresan, is one of the assistant professors of Department of Occupational Therapy in Srihar. A special thanks to Ethos 2021 for providing me with this wonderful opportunity. And also, I would like to thank all the participants of this meeting and also the honorable judge of this event for providing your valuable attention to my presentation and your time. Thank you.
Thank you, Shalini. Interesting how much multidisciplinary effort goes into treating the third most common disease for women. And I think you said the 6th in the world. My question is, you spoke about the need for a therapeutic model to connect occupational therapy and migraine. If I remember correctly, there were some champs, there used to be a model from Calgary that used to deal with occupational therapy and migraine. Where some, I'm not, this is not my primary field, but there used to be some self-management guidelines that they used to give patients, and how to avoid your triggers, and how to identify. Am I right?
Yes, ma'am. So that actually it was one of the.
So how does your study? No. I'm interested in knowing how does what you have used as a therapeutic model compare with what is already existing, because you've not done a comparison with existing models at all.
Yes, definitely. So that's actually there, as you said, it's actually in the Canada, there is a practice of doing self-management, and it has been published in Septalgia. It's like a famous journal just for headache. Sorry.
Can we just request everyone to mute your phones, except of course for Dr. Shalini? Yeah, go on.
Yes, ma'am. So they have recommended self-management strategies for migraineurs, but specifically for people who are having occupational therapy-related problems. Let's say they are having an impact over their job functioning or their work performance or their daily functioning. That means the migraine has been going to the next level of hindering the independence of their everyday living. So in that case, as an occupational therapist, we might use assessments like COPM, which is more client-centered, where we will be like asking the client, what is your major aspect of life that is getting affected due to your migraine? And they might list a few things like that. In my case, my patient talked about her work performance at job. She was not able to concentrate for a very long time, and that she has some aura and problems. So in that case, we'll be
what is the difference in the therapeutic model between what you did and what Calgary did? That's my interest. They teach self-management, identification of triggers and some things like that, and what resources you need. And I vaguely remember that model now.
Yes, ma'am. So
what is the difference between what you offered your patient? I don't want to know how you got to it.
Okay, sure. The thing is, the Calgary, the program, it is a multidisciplinary program. And in occupational therapy, I'm focusing only the occupation part because the name itself is self-explanatory. And the thing is, since our profession is based on evidence-based client-centered practice, I guess that every patient is very unique when it comes to occupation. They have their own things. So we have to do a more thorough independent work on every single patient through case studies and understanding their problems that is unique to their own environmental context, and then start intervening in that level, in client-centered level. So in that case, if we bring up with a therapeutic model that can be generalized for an overall population, then I think that will give a framework, a clarity for all the occupational therapists in the world to set intervention protocols and plan goals for all the migraineurs around the world.
Okay, thank you.
Yeah, ma'am. Thank you so much. Yeah.
Thank you so much, ma'am. Now I request Dr. Kapil to share his screen.
Good afternoon, ma'am.
Good afternoon.
Are you able to see my screen? Is my screen visible, ma'am?
Yes, it's visible.
You're visible.
Myself, Dr. Kapil from LTMMC. So my case report is the Serratia marcescens, a rare nosocomial infection. So it is a human pathogen involved in the various nosocomial infections, particularly catheter-associated bacteremia, UTIs, and infection in ward, and it is responsible for around 1.4% of nosocomial bacteremia cases. And due to its abundant presence in environment, it is a preference for damp conditions like Serratia marcescens is commonly found in growing in bathrooms, especially tile ground, shower corners, and toilet waters and basins, where it manifests as a pink or pink orange colonies and slimy films, feeding off phosphorus containing materials or fatty substances such as soap or shampoo residues. So my patient, a 70-year-old male with no comorbidities, presented with the complaints of right-sided chest pain associated with dry cough since last 6 weeks, associated with dyspnea on exertions grade 1 to 2. On examination, chest shape was bilaterally symmetrical. Right side was moving less than left. Tactile parameters was absent on right side, and the percussion note is hyperresonant over the upper 2/3 of right side and dull over lower 1/3 of the chest. Red sounds were reduced on the right half of the chest in mammary and the inframammary regions. On investigations, HRCT suggestive of right-sided hydropneumothorax with underlying parenchymal atelectasis and bronchopleural fistula. Patient was underwent the procedure of intercostal drainage tube insertion. Pleural fluid routine microscopy is negative for tuberculosis. Pleural fluid culture grows red colonies of Serratia marcescens, which was sensitive to third-generation cephalosporin, meropenem, and levofloxacin. Patient was prophylactically started on anti-tuberculosis treatment as pleural fluid ADA was high. Patient was also posted for right-sided thoracotomy, but the procedure was not done as patient was in intensive phase of anti-tubercular treatment. Patient was diagnosed to have right-sided hydropneumothorax secondary to Serratia marcescens. So in lab reports, all routine investigations are normal, but ESR is slightly raised, and pleural fluid AD was slightly high. So AKT was started on the HRCT report and the pleural fluid studies, and patient was also started on IV meropenem, IV levofloxacin, and supplementary protein powder. So this Serratia is a rod-shaped gram-negative bacteria in the family of Enterobacteriaceae. It's a human pathogen involved in various nosocomial infections like catheter-related UTIs and other wound infections in a ward stay. It is commonly found in respiratory and urinary tracts of the hospitalized adults and the GI system of the children. Infection caused by Serratia marcescens may be difficult to treat because of the resistance to a variety of antibiotics, include ampicillin and the first and second generation cephalosporins. Serratia many times mimic hemoptysis as it produces red pigment called as podigiosin. Rarely upper respiratory tract infections with Serratia produce red pigment, which is mimics hemoptysis many times. So here was my case, ma'am.
Have you finished?
Yes, ma'am.
Okay. Thank you. I'm sorry. Thank you so much. In our days, Serratia used to just be a name in the textbook. But I was under the impression that even today, it is mainly for nosocomial infections or for opportunistic infections. Am I right?
Yes, ma'am.
So what was the case in this 70-plus-year-old gentleman? Because he had no comorbid conditions.
Yes, ma'am. He was.
Why did he develop it?
Might be he has a ward stay for long duration. So usually it was found to be in military hospitals, but sometimes in hospitals like he was admitted for long duration. He might be got it from infected. Yes,
with no comorbidities, what was this long duration of hospitalization for?
He was admitted for hydropneumothorax. He was kept on ICD insertion, and he continuously having ICD tube having persistent output around 200 ml per day for long duration. That's why he was.
I thought you did all that in your hospital. He came with that.
Yes, ma'am. He came with that from outside.
Okay. I would consider that a comorbidity, right? Pulmonary tuberculosis with a persistent ICD in place.
Yes, ma'am.
Would count, I presume, as a comorbidity. I think I lost connection for a short time. Did you mention what was the outcome of the treatment?
Ma'am, with treatment with antibiotic therapy of long duration and AKT, his drain output is resolved significantly. Initially, it was infective, like it was milky, and after antibiotic therapy of around 1 month, it become clear and the output resolved, and symptomatically also patient become better.
Okay. One more question is, you had the patient in your ward. Was he in the ICU at any time? Have you done any ICU swabs to check whether you got this in this organism within your setup? Because if he was in your wards,
no, ma'am, not yet.
Maybe that may help if you could kind of see whether your area is holding it. But thank you so much.
Okay, thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you, Dr. I would like to call the last presenter of this session, Dr. Vaishnavi J.S.
ಎಲ್ಲಿ ಬರ್ತಿದೆ ನಮಗೆ ಎಲ್ಲಿ ಬರ್ತಿದೆ
Mona, can you please call out the name once again?
Vaishnavi J.S.
Dr. Vaishnavi, you there on call?
Yes, I'm here. I'm trying to share the screen.
Okay. Dr. Vaishnavi, are you ready? Dr. Vaishnavi?
Just a minute, I am not able to share the screen.
Can you send your PPT in the group itself? Mona will present for you if that's okay.
Hello? I've
Yes.
shared it on the group.
We won't waste much of time. Till the time, I would request Dr. Shimpa ma'am to please tell a few words to presenters. I know it's always a kind of learning experience to learn a lot from you. I've been working with you constantly, ma'am. And that's why I request you to say anything that you would like to suggest or maybe tell all our presenters who presented for the day.
Well, I mean, I don't have much to say because I'm really impressed with the work you students have put up. I think the level of presentation, the kind of cases you all have selected are more postgraduate level than undergraduate level. So it was nice to see so many PG students on there. I think we'll wait. Dr. Vaishnavi seems to have found the, yes, I think we'll let her continue. And we can give some wrap-up comments at the end.
Good afternoon, everyone. I'm third year resident from Gynecology Department in Lokmanya Tilak College. Today, I'll be presenting case of ectopic pregnancy and fibroid. The highest incidence of ectopic pregnancy is between 26 to 30 years. It is one of the leading cause of maternal mortality. Nowadays, the incidence is increased due to increased incidence of pelvic inflammatory disease, fibroids, tubal surgeries, endometriosis, artificial reproductive techniques, and improved diagnostic tools. And the presentation vary from asymptomatic to hemodynamically compromised. Next slide, please. So my case is 28 years old lady, primigravida, married since 10 months. She presented to emergency department with a history of 2 months of amenorrhea, pain abdomen, bleeding PV since previous day, which is not associated with passing products or clots, and 2 to 3 episodes of vomiting since previous day evening. No history of fever, no history of bladder disturbances and bowel disturbances, no history of loose stools, no history of burning micturition. No significant medical or surgical illness, no significant family history, no history of blood transfusion or drug allergy. Her last menstrual period was 10th of August 2021, which corresponds to 8.6 weeks of gestation. Her previous menstrual history, she had menorrhagia since 1.5 years in the form of bleeding for 8 days at regular intervals of once in 30 days. Next slide. On examination, patient was drowsy and non-cooperative, pulse rate 150 beats per minute, BP 90/60 millimeter of mercury, respiratory rate was 28 to 30 cycles per minute, and also she was using accessory muscles of respiration. CVS and RS examination were normal. Her saturation was 76% on room air. She was looking very pale, clinically around 2 to 3. On responded to all over the abdomen was present. On per speculum examination, cervix and vagina was healthy and bleeding was present. On PV examination, there was left fornicial tenderness and also a mass of 6 into 7 centimeter felt in the left fornix, which is separate, which is not separate from uterus, and it is mobile. And also in right fornix, 7 into 8 centimeter of firm mass felt. And cervical motion tenderness was present. Colpopuncture was done, which was suggestive of hemoperitoneum. Next slide. Her emergency investigations were traced. Her hemoglobin was 2.9 gram %. Total counts 29,100. 2,97,000 platelet count. Her blood group was B negative. UPT was positive. She had come with a USG pelvis scan, which was done outside, which suggested uterus bulky in size with hemoperitoneum with ruptured left ectopic pregnancy with multiple fibroids. Next slide. Relatives were explained about the grievous condition of the patient and need for emergency exploration and salpingectomy, and consent for the same was taken. Patient was immediately shifted to OT in oxygen trolley induced with general anesthesia. Midline vertical incision was taken and abdomen was opened in layers. 500 ml of hemoperitoneum and 450 gram of clots were evacuated. Next slide, please. Uterus this is the intro finding. Uterus corresponding to 18 week size. Under 7 into 7 centimeter left-sided corneal subserosal fibroid was present. 6 into 7 centimeter right-sided corneal subserosal fibroid. Under left-sided ectopic pregnancy at ampulla with bleeding was present. Under right-sided tube was normal. Previous slide. Previous slide. Left salpingectomy was done. Approximate duration of surgery was 20 minutes and blood loss of around 1.2 liter. Post-operatively, patient was shifted to ICU for monitoring. Total of 4 point PRC, 4 point plasma and 4 point platelets were transfused. Later on, after stabilization, USG was done to know the exact number of fibroids in the uterus, which was not seen externally. Next slide. Next. This is her USG. She had total of 8 fibroids. Next slide. This is her USG image. Next slide. Plan of action is a myomectomy after 6 weeks. Mechanical factors predisposing to ectopic are congenital long narrow tubes and diverticula and accessory ostia. Previous tubal surgeries, chronic salpingitis, narrow tube due to fibroid or broad ligament tumor, and functional causes like antiperistaltic contractions, which are commonly seen in patients using progesterone only pills and progesterone containing IUCD. Endometriosis favors embedding of fertilized ovum. In this case, fibroids have narrowed the fallopian tube and they have caused disruption of egg transportation, thereby increasing the chances of ectopic pregnancy. Fibroids have caused distortion of the uterine endometrium, and hence it has made the environment Next slide. The most common clinical presentation is pain abdomen, vaginal bleeding, shoulder tip pain if the patient has significant amount of hemoperitoneum, and vomiting due to stretch of peritoneum, giddiness due to anemia, and ruptured ectopic will present as acute abdomen with hypovolemic shock. Next slide. Sites of ectopic. 95% of the ectopic are tubal and 5% are. Next slide. Next slide. The ectopic pregnancy, abdominal, cornual angular pregnancy, pregnancy occurring in blind rudimentary or no bicornuate, cervical pregnancy, ovarian pregnancy. Next slide. Ethical issues related to this case are ectopic pregnancy is a medical emergency that requires prompt immediate treatment to prevent maternal mortality and morbidity. It is one of the leading cause of maternal mortality, causing around 3% of maternal mortality. Ectopic pregnancy has a negative impact on future fertility. In this case, my patient was an early gravida and other treatment options were not feasible because she reached us very late. So the salpingectomy was the only treatment modality available. Next slide. In this case where fibroids are the reason for ectopic, taking the consent only for salpingectomy and explaining the relatives about the second surgery for the fibroids after 6 weeks was difficult. Because in that situation with hemoglobin of 2 g/%, we couldn't proceed with the myomectomy. And explaining the guarded prognosis of the patient was difficult because her blood group was B negative and availability of blood was difficult. On reliable diagnosis, prompt treatment to remove ectopic pregnancy is legally justified and ethically and legally required. Thank you.
Ma'am, you're muted, ma'am.
Yeah, thank you, Vaishnavi. Ectopic pregnancy is really out of my purview, but I'm just curious, when you presented the history of ectopic, Did you
Yes.
ask her for history of smoking? I don't remember
Yes,
you mentioning all these things.
No, ma'am. She was
Yeah?
non-smoker coming from a rural area,
Yeah.
but it was not mentioned there.
was
Smoking
not
predisposes to
mentioned.
ectopic pregnancy.
Yeah,
It
because see,
damages
when she came to you, you had a 28-year-old lady with no predisposing factors. Am I
Yes,
right?
yes.
Fibroids to baad mein pata laga na?
Yes.
Yeah. So the common things I remember as an intern now, my gynae is like internship gynae. We used to ask whether you're a smoker, and I even remember we used to ask whether she's having any panic attacks, any hyperdepressions, any psychological disorders. Am I right? That also is supposed to have
ma'am.
some link with ectopics.
Yes, ma'am. Yes.
Yeah. So maybe you should cover all these. It would be nice. I'm very interested in seeing the fact that you all went in for an emergency salpingectomy. They used to say salpingotomy or salpingectomy, right?
Yes.
What is the current thinking on that? Just
Ma'am, if the patient was stable, if there was no hemoperitoneum,
Okay.
and if the ectopic was unruptured, we could have done salpingostomy as she is nulli gravida. But it was
Okay.
not possible in this case because the bleeding from the ectopic was present and it had already caused hemoperitoneum.
Okay, so that was the decision for salpingectomy.
Yes.
One more question. How has transvaginal USG made any difference to ectopic gestations? Diagnosis or anything? Because I noticed you all didn't use it, so I'm just curious.
Ma'am, she already had got a scan which was done outside. USG pelvis was done. We really did not have time for USG and all because her saturation was less,
very bad.
lot of blood loss. We proceeded with the colpopuncture and the diagnosis of ectopic was almost
obvious.
sure.
Yeah.
Yes. So we immediately took her for section.
Okay, fine. Thank you, Vaishnavi.
Thank you.
I think that brings us to the last presentation for today.
Yes, ma'am. We have done with the presentations. And thank you so much, ma'am, for your time and wonderful judging all the presenters.
I can't hear anything, but that's fine.
Now am I audible?
I guess, Mona, you need to mute Chavan, I guess, Dhanashri Chavan. Please mute her. Go ahead, Mona. Shravya, you there? Shravya, Mona?
Yes, sir.
All the sound is
Okay, ma'am, here I would like to take opportunity to thank you. I guess both of them are having some internet issues or connectivity issues, ma'am. Thank you so much once again, ma'am, for this for gracing this occasion. I know like you are packed up with your schedule, but still you agreed to judge at the end moment, ma'am. That was so a moment of happiness for all of us. We have been working together with you, and there is always something to learn from you all time, ma'am, to be honest. And I am very sure that all presenters have also learned a lot from today's session, ma'am. Ma'am, also, is there anything that now you would like to tell to all our presenters?
Well, first of all, congratulations. I was really very happy to see the level of presentation, the topics they had chosen, the kind of work that has gone into those presentations that they have made. Overall, I think presentations were good. Some guidelines of how PPTs are to be made are always left. All of us do that. I think we all have something missing from our PPTs. But one thing, when you're presenting a scientific presentation, the less text you have and the more tables and diagrams and flowcharts you have, it's easier for the audience to track what you're saying. Too much text, especially where you have repetitive text, stage 1 showed so many milligram percent, stage 2 showed so many milligram percent. A table would probably be easier for us visually to see. So that was one thing I just thought I could emphasize. though of course a lot of you have put beautiful images, lovely tables, and that was very welcome. I noticed nobody uses algorithms, and perhaps using algorithms for methodology, using algorithms for management protocols would save a lot of time and number of slides. So that is something that could be done. Beyond that, I think excellent job, very well done. And I must admire your moderators. You've been shuffling people up and down. You've been guiding people how to access, how to screen share, the interruption because we started late in the morning, splitting this into 2 sessions. I think very smoothly done, very nicely done. It's such a pleasure to see this. Congratulations, keep it up. And thank you for having me here. It was wonderful. I always love seeing students and the work they're doing. It kind of inspires me backwards to do better. So thank you for the inspiration. Thank you for the invitation. Yeah, thank you.
So
And
much,
all the
ma'am,
best.
for your kind. Ma'am, the main driving force behind this conference is our Dr. Shiv Joshi, sir. He was the one who took a pioneer in organizing Ethos conference, ma'am. And I would now request Shiv Joshi, sir, to kindly say a few words. And also, thank you so much, Mona, Shravya, for taking out this event so smoothly, efficiently, and cooperating with all our presenters. Shiv Joshi, sir, over to you now.
Thank you, Shubham. First of all, I would like to thank Shimpa Sharma ma'am because for 2 reasons. Because I know she is very busy, and being a senior faculty, sometimes it becomes difficult to spare time. And she not only came for the first part, but also cooperated with us for that interruption. So thank you, ma'am, for being there with us to judge this event. I also appreciate that the way the presenters showcased their scientific work here. That was really nice. I totally echo what Shimpa ma'am has said, that we are all very junior researchers as of now. And learning is a process. It's not a destination, right? It's a direction. And I think this platform has just given that direction to all of us under able guidance of teachers like Shimpa ma'am and all our other judges who have spared their valuable time to not only judge this competition, but also to give valuable insights into how to improve the research or how to improve the way we present the research. So I think that's really heartening to see. Moreover, of course, all the coordinators of the scientific committee and Shubham, Mona, everyone, Shravya, Harshita, everyone, you have done a great job, and I hope you'll keep this up for the remaining sessions. One more day to go after today, and I think we'll all keep it up and do this in the best way possible. Thank you. Thank you, ma'am.
Thank you so
much. Thank you so much, sir. I would now request everyone to please switch on the video cam for a group photo. Yasha, Chavandanishri, Dabuta, please switch on your video cam. We'll take a group picture. Mona, you're taking? Done?
Yes, sir. Thank you so much, ma'am.
Thank you so much, ma'am, once
Thank
again.
you so much. All the best.
Thank you
Thank
so
you,
much,
ma'am.
Mona, Shravya.
Thank you, everyone.
Thank you.
Thank you, everyone. Thank you, Shiv and Shubham.
Thank you so
Thank
much,
you, Dabota.
Dabuta. I was
Thanks for
waiting for
joining.
was